Must be kind of confusing having all these different people come in.
It's a new person every time, but fortunately you have your name written down, and so I can call you by your name. It would be much harder if we were around the horseshoe and I had to just remember what everyone's name was.
Yeah, I know it is. I kind of like this. Everybody's name is there. So.
All right. Good morning and welcome to the Joint Standing Committee on Health Coverage Insurance and Financial Services. We have a number of work sessions scheduled for today, and so we will begin as we do with committee introductions, and I will start with Representative Arford.
Thank you very much, Madam Chair. Good morning to everyone. My name is Poppy Arford. I represent State House District 49, which is the western part of Brunswick.
And is Representative Quint there?
She is.
Yes, I am here.
Go ahead.
Thank you. My name is Tracy Quint, and I represent House District 144, which includes 13 towns in Aroostook County. Thank you.
All right. Representative Connor.
Good morning. Thank you, Madam Chair. My name is John Connor. I represent House District 58, which is part of Lewiston.
And Representative Matheson.
Good morning, everybody. My name is Christy Matheson. I represent District 1, Kittery.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Mark Blyer, and I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Representative Melrano.
Good morning. My name is Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and Livermore.
Senator Brenner.
Good morning. Thank you so much. My name is Stacey Brenner. I represent Senate District 30, which is all of Gorham, most of Scarborough, and part of Buxton.
Senator Stewart.
Morning, folks. I'm Trey Stewart, State Senator in District 2, which includes 51 communities in southern Aroostook and northern Penobscot counties, including the town of Hammond.
Representative Tepler.
Good morning. It's very nice to see everyone. It's rare we have the entire committee present, so great to see everyone. And I represent House District number 54, Denise Tepler, and it's all of my sweet town of Topsham. And I also serve as the House co-chair of the committee.
And I'm Heather Sanborn. I represent Senate District 28, which is half of Westbrook and half of Portland. And we are assisted today by Darlene Simoneau and Colleen McCarthy-Reed. And the order of our bills today will be, hang on, I've got to find the right screen here. We will first take up LD 41 and 686 in a unified work session. Then we will, I think, potentially pause because we need to check in with us a little bit of a caucus on LD 120 and 749. So we may pause before we take those two up, or we may push them off a little bit, but those will be worked together. Then we will take up 673, 1117, and 675, likely in that order. So that's sort of how we'll approach the work that we have in front of us today. And like I said, we may move the Office of Affordable Health Care work session a little bit later so that we can check in with the sponsor at lunch or whenever he becomes available. Okay, so with that said, the first two bills that we're going to work on are prescription drug transparency bills that are on the calendar for today. And those are LD 41 and LD 686. And so Colleen, I'm not sure, you've definitely got a separate analysis for 686. We may want to start there, or you could start by reminding us what 41 is all about, because I think we previously worked on it and the public hearing was a long time ago.
We have, sure. Okay. So if you'd like me to go through the analysis. We'll pull up LD 686 first. LD 686 is an act to increase prescription drug price transparency. It amends the laws, the current law that governs prescription drug pricing in a couple of different ways. One, it removes the requirement that manufacturers provide notice to MHDO of triggered changes in wholesale acquisition costs of a prescription drug, and instead requires MHDO to post on its website a list of those prescription drugs that hit the trigger that's defined in statute. It provides that MHDO must annually notify reporting entities with 30 days advance notice of drug product families for which MHDO intends to request pricing component data, and it adds to the statute a specific definition of drug product family. It also clarifies that MHDO is authorized to request data for any drug it considers relevant to providing greater consumer awareness, with emphasis on drugs that trigger those WAC changes, or drugs that are included in the MHDO's top 25 drug reports as required by statute. And as you'll recall, MHDO is required to identify the top 25 drugs utilized and prescribed in the state. And then lastly, it modifies the pricing information that MHDO may publicly report to allow identification of specific drugs, reporting entities, and some publicly available pricing information on drugs, as long as specific contract terms are not disclosed. There are some provisions in current law that I just alluded to that LD 686 seeks to amend those provisions in statute, and those were enacted in the 129th legislature. And under the current law, prescription drug manufacturers are required to notify MHDO by January 30th annually if during the previous calendar year the manufacturer increased the wholesale acquisition cost of a brand name drug by more than 20% per pricing unit, if the wholesale acquisition cost of a generic drug that costs at least $10 per pricing unit was increased by more than 20% per pricing unit, or the manufacturer introduced a new drug for distribution in Maine when the wholesale acquisition cost is greater than the amount that would cause the drug to be considered a specialty drug under the Medicare Part D program. So those three sort of triggers are what would require or let MHDO ask for additional information from those manufacturers for those drugs that meet those triggers that I just described. And under the existing law, MHDO may request information relating to a specific prescription drug that meets one of those triggers, and manufacturers, distributors, or pharmacy benefit managers are required to provide that information about pricing component data to MHDO within 60 days of a request. And then MHDO also is required to produce and post on its website an annual report that includes information developed from these notifications and disclosures on trends in the cost of prescription drugs and an analysis of prices and price increases. The first report was submitted by MHDO in February of 2021, and the committee did have a previous presentation from them about the first annual report. One of the items that I mentioned that's included in LD 686 is a definition of, adds to the statute a definition of drug product family, and then would authorize MHDO to request information about pricing related to drugs that are within that drug product family. We did have some concerns raised about whether this might expand the scope of the entities that MHDO will ask to report information. You've received some concerns from manufacturers, distributors, and pharmacy benefit managers about the impact of including this language and the increased reporting requirements. The bill would clarify the statutory authority to require reporting related to drug product families, and LD 41, which we considered previously, would provide final authorization for MHDO to adopt its amended rule, which establishes uniform standards for reporting that data to MHDO. So LD 41, you might recall, also puts into the rule, MHDO's rule, a definition of drug product family, which is consistent with the statutory definition in LD 686, and sets forth sort of the uniform data sets, and that MHDO will require manufacturers, distributors, and pharmacy benefit managers to report to them related to those particular drugs and the pricing component data that they'll request. So that's how sort of these two bills interrelate. LD 686 is the statutory changes, and then LD 41 are the corresponding rule changes related to drug product families and the other uniform standards for reporting that data to MHDO. You did have a suggestion related to the added definition in the statute of a prescription drug in the bill. Maine Community Health Options suggested that the language might be clarified to refer to both dispensing and administering of a drug by prescription. The statutory definition as drafted now refers only to dispensing of a drug by prescription, and they suggested adding reference to administration of a drug by prescription. And then also additional concerns were raised about the expansion potentially of allowing of the confidentiality provisions or the public reporting provisions that would allow identification of specific drugs. But as I mentioned, the bill does put in place language that would permit the disclosure as long as it's not released in a manner that would allow the determination of individual prescription drug pricing contract terms, although it would remove the current restriction for identifying a particular prescription drug. We don't yet have fiscal information on this bill. I'm happy to share the analysis again for LD 41 if that would be useful to you, and go over the specifics of sort of the data standards that are put in place in that rule. And I'm happy to answer any other questions. And I do know that I believe Ms. Harrington from MHDO is also here and can respond to any of your specific questions about either LD 686 or the proposed rule.
Thank you, Colleen. Are there questions about these drug price transparency amendments? All right. So is there discussion amongst the committee about these bills? Senator Brenner.
Thank you, Madam Chair. It would be helpful for me to hear from Ms. Harrington, if that's okay.
Sure. So I'll bring in Karen Lee Harrington. I'm doing it right now.
Okay.
Good morning, Ms. Harrington. Nice to see you.
Morning, Senator Sanborn. I just want to let you know I asked Jim Jones, who is our expert, to also attend, and it might be helpful depending on the questions that you have, that he also.
I'm bringing him in now.
Thank you.
Mm-hmm. All right, Mr. Jones, you can activate your camera and your microphone when you are with us. Perfect. Okay. Senator Brenner, do you have a specific question that you want to start with?
Mr. Jones, I would love your thoughts on the amendment and whether you think this will be effective at achieving our goal.
Well, I certainly think it helps further your goal. One of the main components is that we want to clarify that MHDO has the authority to request information on any drug that really helps to focus in on what's causing the cost to rise in the state. One of the elements that's been a bit confusing is whether or not MHDO has that broad authority. There are two sections of the current law, one specifying that manufacturers have to notify MHDO if they hit certain triggers, and then a subsequent section of the law that talks about MHDO requesting additional information from manufacturers, wholesalers, and PBMs. In their interpretations that the two sections are combined, and that MHDO may not request information for specific drugs that don't hit the triggers. What we are trying to make sure that we can do is look at all of the drugs that are in a drug product family, so that when you have certain drugs that go up in price, you also have access to information about the other drugs that would be equivalent or at least within the same therapeutic class, where you might have alternatives that might have a better price. One of the nice things about the law in Maine is that with all of the various supply chain entities that do report, you have better access to the actual net price, which is certainly a benefit. Whereas if you're just looking at WAC price, you can't really tell whether the consumer is paying a higher or lesser price as those prices adjust without access to the rebate information. So really just to come back around to it, by adding the drug product families and removing the ambiguity around whether the two sections of the current statute are intertwined, you open up the data set so that you can look at competitive drugs in the market.
Thank you for that.
Okay, are there additional questions for Mr. Jones or Ms. Harrington? Okay, I guess my question is whether the draft that we have of 686 will solve what I perceive to be the biggest weakness with the first report that we got this year, which was that we were told a drug went up by a percent, but we didn't know any information about that drug. I think we were told it was a generic that went up by the greatest percentage in the report, or that was highlighted, but we couldn't be told which drug it was. And so it felt very meaningless, to be honest. Does this bill as drafted solve that problem?
It does. It removes those restrictions on specifying a specific drug or reporting entity from the confidentiality section, but it also adds language that will protect all of the reporting entities. There's definitely concern around trade secret or proprietary information involving rebates and those contractual terms between entities. And so the confidentiality clause protects that while allowing us to provide drug-specific information.
Okay, great. That'll be a big improvement for sure. Okay, are there any additional questions for our panelists? All right, seeing none, I'm going to send you guys back through the wormhole, and we thank you for being here. And we may need your assistance on later bills as well, so I hope you'll stick around. Okay, so now committee, and we did get Representative Evans as well. We had a little issue getting him into the meeting, but he's here now. Representative Evans, would you like to introduce yourself? You're on mute.
Thank you, Madam Chair. Sorry about the delay. I'm playing with two different computers. I am Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Hornerville Township, and Lakeview Plantation.
Great, thank you, Representative Evans. Is there discussion on these two bills, 41 and 686? Senator Stewart.
Thank you, Madam Chair. I think it'd be helpful to get the perspective too from the folks that represent the generics as well, to make sure that the challenges with this bill are actually dealt with through the amendment. So would it be possible to bring out, I believe Ashley Van Meter is representing the association for the generics. Would that be possible to bring her in?
Sure. Good morning, Ms. Van Meter. Your wormhole was snappy this morning. Welcome. All right. So Senator Stewart, do you have a specific question you'd like to pose to Ms. Van Meter?
Well, I guess just generally, can you comment on the language in the amendment and I guess share your thoughts on what the implications are of the
Sure.
bill and the amendment as well, please?
Sure. So specifically, the underlying legislation that created the requirements to report and the triggers of reporting. The generic industry worked hard with groups like NASHP and also with Senator Vitelli to make sure there were standards put in place so that the right drugs that were actually driving costs for Mainers were being reported. When you use pure percentages, a lot of times you're getting, it may look like a 200% increase on a generic drug, for example, but it is a drug that costs 11 cents. And so we're not talking about a drug that costs $30,000 for a course of treatment, like some of the specialty products or biologics and such. And so those triggers were very important so that companies that really are doing nothing wrong aren't getting swept up in some of these reporting requirements, which are quite burdensome for some of these companies that are smaller. And so by expanding that to the drug product family, say you have a brand, or even say if it is a generic company that does hit those triggers, and now every drug in that product family is forced to report when they've done nothing wrong, they've worked to ensure through compliance that they're not raising their prices to hit those triggers. These companies have to go to over 12 different departments to get this information. It is burdensome. And additionally, the information that is being sought is available to the state already through state Medicaid. You can get the documents, you can get the names, you can get the information, even the amps, the wax, everything. And so also since the state of California put a bill in place and have a law, you can currently get every drug price that hits triggers that are much higher than Maine's, or lower than Maine's actually, and get that information. So to put this additional burden on generic drug companies that operate on really slim margins to provide cheaper medications for people is incredibly burdensome, and you might force some of the companies out of the marketplace. So that's our concern, is burdening companies that really did nothing wrong just to get a look at data that's already available.
Ms. Van Meter, I'm a little puzzled by the idea that it's burdensome, but that the information is available if we just go ask California, because doesn't that mean that those generic manufacturers would have prepared the report for California?
The problem is we've now have, since each state is doing something different requirements, different data sets, and different types of information is being sought. But if it's a situation where, someone hit a trigger in Maine, but you just want to look at the entire product family, you as a state have the ability through state Medicaid to look at all of that information. That's where you would get that. And California is it's a supplement, since it's a national price really for generics. It's not done state by state through the contracting that we do. California does have some of that stuff available that you could pull from there as well. And so having those things available, I think, is pretty much what you need if you don't want to burden companies that really didn't hit any of those triggers. Because a lot of even the data that was pulled in conversations that I had with Maine Health Data Organization, the drugs that were truly driving costs in the state of Maine, yet maybe a couple of generics got put on there, and they deserve it if they're on there, then they should report. But for example, like a Lipitor, a branded Lipitor, there's some over 30 other manufacturers of generics that would then have to turn over information that, when they did nothing wrong, when they're in fact providing the medicine on cents on the dollar.
Okay, I go back to the issue of, and this always gets classified in this way, but we're not trying to punish manufacturers by asking for data. We're trying to get transparency and
Right.
insight into the games that are played so that we can help consumers. So I want to sort of say that for the committee. That wasn't really a question for you, Ms. Van Meter, but we're in a work session. So Senator Brenner, I think you were next.
Thank you, Madam Chair. Ms. Van Meter, is there a way that we could ask you for the data in a certain form that would not be burdensome, that you could provide directly to the Maine Health Data Network in the way that you provide to other states? Your member organizations could provide. Like, it just strikes me as like I'm also puzzled. Like, I don't understand why the data, if it exists, is difficult to submit to the organization here in Maine.
Well, the issue,
I guess the other question I have is there something about it being publicly available that's troubling for you?
I mean, that is part of the concern as far as some of the proprietary information, but more importantly, we don't prepare those reports unless we hit triggers. And so if our companies are doing everything they can in their pricing to make sure that they don't run afoul of the legislation, for example, the triggers that were cited in the beginning from the previous statute, they don't then compile all of that data. They don't have it right there. They do it if they know they've hit the triggers. And so they build into the process of when they're getting their information to be able to turn over to different states, making sure that they don't hit those triggers. And so it does feel like a punishment. It feels like you did nothing wrong as far as our underlying statute, but we still want your information. And that's why when we were negotiating back and forth with the underlying statute, we supplied data showing without those triggers, you could, in the state of Maine, get a list of like your 200 cheapest drugs. And that's not going to show Maine where you're spending too much money. It's going to show Maine that a lot of people take that cheap drug. And so it was very important to put those parameters in place so you get actual data that shows you what is driving cost. Not, 11-cent drug, but maybe a drug that we do see that costs $30,000 a month. You want to see that sort of thing. And I understand that you want to see, what happens if this drug goes up? What are all the other drugs in the product family doing? And I think your underlying statute is working in that companies have adopted that into their pricing mechanisms, saying, don't hit that trigger, don't go above it. So you have effectively have manufacturers say, we're not going to price beyond that because we don't want to have to get all these reports together. So it is in fact driving down costs.
Is it the reports that would keep the company from not raising their price, or is it the being forced to have transparency that would keep the company from not raising their price? I guess what I'm having trouble with is like, you want to have a free market pharmaceutical experience here is what you're asking for, but yet you're like unwilling to also offer price transparency. And I just feel like there's some—
We're all for transparency, because if you look at our drugs, we are always going to be the cheapest option in pretty much every market with generics.
Wouldn't you want all of Maine to know that then with a price transparency bill?
I think that they do know that. I think that's why folks do gravitate towards, that's why we're 90% of prescriptions dispensed. At least the pharmacists know it, and substitute, which honestly was really hard to get to that number because there was a lot of work being done behind the scenes to make sure that brands were still preferred. But I mean, we don't have a problem with transparency, but just for transparency purposes, I was always under the impression, and I think our manufacturers were, that these bills were aimed at reducing drug costs. And so you wanted to see what is driving costs. So if you don't have a drug that is raising their price at all, or they have actually decreased their prices, which is the trend in generics over the last decade, our drug prices have gone down 10 years in a row. Why should that company then be punished to have to report like the company that did? I
don't see it as punishment at all. I see it as celebration. Let's have a transparent celebration of how well you've done, and let's publish those prices for Mainers to see.
Yeah, but unfortunately, it costs the generic drug manufacturer money to pay people jobs, and also getting those reports together, filing the reports. And I know that there are a lot of drug companies that make billions and billions of dollars, but I can tell you that most generic manufacturers run on very slim margins, and that's how we're able to provide value to consumers.
Thank you.
Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. Van Meter. I, in fact, want to be very clear that I am really not interested in punishing or in creating problems for generics manufacturers. However, I want a more clear picture as a policymaker of what drugs are priced low, what drugs are priced high. And as a policymaker, I feel like I need that information to make good choices when I create policy. And so I'm very confused by your sense that the need for information, for me, these bills are not just about driving down costs per se, because what we need to do to drive down costs is understand what the spread of cost is and where the pinch points are. So if I know that clearly generics manufacturers' prices are consistently lower than, and I don't know that now, I have no data to support that. You can say it, people may think it, but I don't have the data to back it up. So
well, I would urge Maine Health Data that if they use the underlying statute and they take the drugs, the list of the drugs that are the most costly in the state from another statute that was put in place that we helped work on, and the list that you come up with through the triggers. If you take those drugs and you see these are the drugs that are driving the prices in Maine because of the amount of people that are on it and or the amount of money that it costs to buy these drugs, to then have Maine Health Data Organization provide from Medicaid and from the publicly available documents that you can get from like IQVIA, other places that get this data, and give you folks the comparables so that you can see the spread.
I have a feeling that doesn't give us all of the information. And so I understand that you want us to use the available data, but it's often not created in the form that it needs to be put into the database that we're using. And so we've been asking you to do that, and I continue to be confused about the cost. I'd love to know an estimate from you exactly how much it costs for one of the manufacturers to produce one of these reports for us.
I can find that out. I don't know the exact number of what it costs to fill one particular report. I do know that it's becoming increasingly more expensive. We've tried to go with and work with NASHP to get a model bill, which is what Maine was the first state that we moved forward with our negotiations with NASHP, to get that model bill so that it was consistent across all 50 states so that you were getting the right data that you wanted. But unfortunately, people in every other state did something a little bit different. They tweaked it a different way. So a lot of the problem is these companies are having to do, it's upwards of 25 to 30 different types of reports with different type of information, all of which is somewhat proprietary, that they're having to put together. Some of the companies have had to hire multiple additional people that cover the pricing issue because it's become, and rightly so, it's become an issue that folks are concerned with. And it's, I think it's hard for our members to see, well, when we're 2% of overall overall healthcare costs, why are they focusing in on us so much? Why aren't they focusing in more on other parts of the supply chain? when we're the only one that is truly providing savings, our prices are going down every year. So it's just, I guess, it's one of those situations where agree to disagree kind of thing, because we feel it's just incredibly burdensome. And we felt that we've honestly worked with the committee, with legislators, with outside groups to make sure that you all had information that was meaningful for pricing information, and not just to have information for information's sake that wouldn't be helpful.
I would like to make one further comment, and that is that we ask similarly of providers and our hospital systems to provide us with information on certain procedures and the cost of those procedures. And we publicly display that. And yet not one system has come to us and said, you're punishing us for the cost of a procedure. So I am in fact confused by your concept here, and I think that I don't understand why sharing information about the spread of medications is such a burden.
Okay, I could just say, I think it's probably because throughout the process of the underlying legislation, most legislators were saying that it was being done as a punishment to folks that were hitting those triggers, saying you have taken an inappropriate price increase. So now you're going to turn over your information so we can see why you're doing it. And so, you know, we went back to our manufacturers and said, you got to make sure that you're pricing in a way that is not going to hit these triggers, so that you're not doing something that is deemed wrong in these states. And so I think the message that we received throughout, you know, through we're curbing drug costs, we're bringing down drug costs, you know, the manufacturers who are out of control, they're not going to, you know, get away with it anymore. Those sorts of things were somewhat of the message that I think that our members took away from the negotiations of the underlying legislation. So to us, it seemed like this information was being requested of bad actors. And so we did everything we could to make sure we weren't part of the group of the bad actors. And then it somewhat feels now like we're just going to get pulled in there anyway. But I understand what you're saying, and I just respectfully, you know, disagree, but have always worked well with the committee, and am here to answer and get any other additional data and things that I can as you all try to work to bring down drug prices for Mainers.
I think I have to take over for Senator Sanborn, as power apparently has gone out at her home. I am turning to the committee to see if there is further discussion on either LD 686 or LD 41, which are the two bills we're currently working. And thank you, Ms. Van Meter, for your patience and being with us and explaining your point of view.
Representative Tepper, I'm going to have you chair for a while. I'm on my phone and can barely connect.
Yes, thank you, Senator Sanborn. Good luck. We hope that you will be able to reconnect with us soon. Is there anyone else who has any further comments? No. Can I have a motion on either one of these bills? Yes, I see Representative Melorano.
Thank you, Madam Chair. I just wanted to let you know that Ms. Karen Lee Harrington did have her hand up from, I don't know if you wanted to pull her in or not.
Thank you. I think we do want to pull Ms. Harrington in, and may have a few questions for her from the committee.
Representative Tepler, if you could also pull in Jim Jones, that might be helpful.
Thank you, Karen Lee. I will ask Ms. Simino to please pull. Darlene, can you pull them in? Pull him in, I should say.
Yep,
Jim
if I can
Jones.
find him, I will.
Great.
He's already here, Darlene.
Oh, that's
Thank
why
you.
he's not in my list.
Thank you, Colleen.
Thank you. So I just wanted, if okay, I wanted to just make a couple of follow-up comments to the discussion that you just had. So one of MHDO's guiding principles is to really try and minimize the reporting burden for those that are reporting data to us, whether it is hospitals, payers, pharmaceutical companies. That is critically important to me, to my board. We recognize that there are limited resources everywhere, including MHDO. And so we have to try and figure out the best, most streamlined ways to work with our data submitters. So I wanted to put that out there. And that is one of the reasons why there is a provision in the bill that is eliminating the requirement for the manufacturers, the wholesale distributors, or excuse me, the manufacturers, just the manufacturers, to report to us if they have a drug that hits one of the triggers. We are going to go out, we've purchased a license from a database that we can go get that information. So that minimizes some of the burden for the manufacturers.
So Ms. Harrington, am I understanding correctly that the concern that Ms. Van Meter expressed about reporting is now eliminated because generics manufacturers won't have to report? You're going to go out and collect that information?
So it's not eliminated because there are two steps to the reporting requirements. The first step is they have to notify us if a drug hits a trigger. That's the current requirement. We are proposing that we remove that and MHDO will go get that information. The second part of the reporting requirement is when we pull together the list of drugs that we're interested in collecting further information on the pricing, which this data, not all of it is publicly available. So some specific examples, and Jim can jump in with more details, but we don't get rebate information in the Medicaid data. We don't get net revenue information. And I also am not sure that there is Maine specific data, which was one of the requests, right, from the reporting entities, that they wanted us to only focus on those detailed data elements for Maine and not nationally. So in order to do that, we need folks to report for Maine. So we, so that requirement, you know, it still is a burden. Let's be honest, it is a burden for these folks to pull together the information. And that is why we are trying to minimize and focus what we are asking for. And Jim, please check me if I say anything wrong, but just high level, there are about 30,000 NDCs. In our first report, for the entities that we can ask for drug pricing information beyond just the trigger drugs, so for the wholesale distributors and the PBMs, we asked for a total of 218 drugs. And 170 of those, or 170 were for the drug product families. So I just want to put it in a little bit of perspective that we're not asking for thousands of data points or thousands of drugs where they have to provide additional data. We are trying to stay focused and tight because we can't process all of that information, right? So that's, you know, really important to us, why we've added the additional language to focus on the top 25 reports and pulling drugs from there, is again to keep this focused. And that is, you know, what my board has, you know, said, that it's critically important that we're focused and not asking for thousands of information.
Thank you, Ms. Harrington. Senator Brenner has a question for you, so I'm going to go to her and ask her to go ahead.
Thank you, Madam Chair. Yep. Ms. Harrington, so you explained that in these reports, you're looking for cost information, rebate information, net revenue information, and then main specific information. So when it comes to you, is it electronic? I'm assuming it's some spreadsheets. I mean, I'm assuming this is information that any large corporation has in their database for the sales that they're making.
So I can share with you. So yes, it is, the data structure is in a spreadsheet. We talked to the reporting entities before we put together the process for data submission to find out what would work best. And so I think what we've created is what the majority of the reporting entities had indicated that this works. And I will say, we've got now 1 year's worth experience collecting this data. And I don't think that we had significant issues with the reporting of the data. Mm-hmm. And Jim, I don't know if you want to jump in, but I think that folks were able to comply with the requirements in terms of the detailed data elements.
And does it at all mirror what other states are asking for, so that there's not a lot of reinvention for companies to find different ways that they need to comply with different strategies for reporting their data?
I think, as was previously discussed, I think the challenge is, there was a common structure that NASHB had put together. Mm-hmm. And I think we've all tried to use that as a starting point. But then I think, every state has, possibly slightly tweaked that baseline for various reasons. And so it's not, but I think the starting point is consistent. And then I think that the majority of the data elements are probably consistent, but then there are some unique state by state.
Mm-hmm.
If I can jump in just for a minute, I think I've worked with a number of the states now, and really California started the process of this data collection in 2017. They had a law that went into effect at the end of 2017, so it's only been a few years here. But as things have evolved, and certainly in Maine, we've tried to move away from just WAC-based reporting, and a lot of that's based on the feedback from manufacturers that it doesn't provide the whole picture. We're really just looking at list price, and we can use that because it's common across all manufacturers, so it's a steady baseline. But what's really important is to get into the net costs so that you can really make good decisions in policy around how best to provide cheaper products to the population. And so in Maine's law, there are some unique data points around sales volume, around revenues and rebates specifically, that help us to ascertain if there are cheaper manufacturers, whether they have the capacity to ramp up to compete in the market. Are they just, Me Too manufacturers that can only produce 10,000 units a year, or do they have capacity? Some of these things are really digging a lot deeper than the surface laws that were early in the process.
Thank you. You're muted, Madam Chair.
Thank you. I was trying to find myself and my button as people moved around the board there. Thank you, Mr. Jones. Appreciate that perspective. And are you all set, Senator?
Yes, thank you. That was very helpful.
Yes. Okay. And I believe that Representative Morris is next.
Yes. Thank you, Madam Chair. Question is for Karen Lee Harrington, just around the issue of defining the drug family in 686, as well as what's identified in the rule in LD 41. Is that sort of the idea, to define it in 686 to justify the rule in LD 41?
So I consulted with my Assistant Attorney General with the changes that we wanted to make in the rule. And although we feel like we have broad authority in our underlying statute, we did think that for purposes of transparency with the reporting entities, it would make more sense, or it would just be better if we constitute in the law. So that's why it's there. But again, we feel like we have the broad authority that we could do it without a change in the law. But I think just having it in the law gives everybody more of a comfort that it is explicitly stated.
Okay, thank you.
Thank you, Representative Morris and Ms. Harrington. Representative Bleier, please go ahead.
Thank you, Madam Chair. Thank you, Ms. Harrington, for being here. I guess my question is, one key point that you mentioned is that all the information, everybody has the same starting point, but the state of Maine would have a little bit different information. So all the companies reporting would have to give a specific report specific to the state of Maine. And so there is a workload there that's important to understand. But my question to you is that the 129th put in the first legislation that we're kind of pulling away that trigger point, and now we're coming up with different requirements in order to give the information. Will there be more reporting now with this new law compared to what was implemented in the 129th? The triggers triggering, or whatever's triggering the reporting today, will there be more reporting, do you feel, than there was in the past?
So I think there'll be more of an opportunity to, I guess the short answer is yes, because we will be able to ask the manufacturers for data on drugs that don't just hit the trigger as defined in the statute, but also are part of our top 25 most costly, most utilized, and with the highest year-over-year increases in our top 25 reports. So that, you know, to me, looking at the drugs that Mainers are using the most and that are the most costly is to some extent more important than the drugs that are hit a trigger. And so that's where I really want to focus on those drugs that we're using the most and they're costing us the most. And there is some overlap. And Jim, I don't know if you remember, but this was in our first report. We had identified where that overlap was. How many drugs that hit the trigger as defined in the statute were also drugs that were part of our top 25 reports. And I think if I'm remembering correctly, there was somewhere around 10 to 14.
There was some overlap. We certainly also did a cross-check against the APCD pharmaceutical claims to make sure that any data that we were requesting information for was actually, that they were actually drug products that were being utilized in the state of Maine. So there were some, for example, there were a couple of generic drugs that had very high price increases, but were only utilized for 100 claims during the 2019 time period. And so that would not be an area of significant focus where we would go and request additional information. Whereas if some of the drugs landed on 2 of the top 25 lists, those were definitely the drugs that we went and asked wholesalers and PBMs to give us more information about.
And what the change, if you enact this this legislation, the change will be that we can get that information from the manufacturers as well. What we did in the first year is, again, we felt like we had that authority. We have broad reporting authority under our statute. The manufacturers pushed back and were concerned. And so we said, you know what, in the spirit of collaboration in this first year, we will agree that we will just ask for information for those drugs that hit the trigger from the manufacturers. The way the law is currently written, we can go get that additional information for the drug families from the PBMs and from the wholesale distributors, and we did. And so what we're simply asking is, we'd like the authority in statute so that all the parties are clear, that we can also request information, more detailed pricing information from the manufacturers on drugs beyond just the trigger. And it may be that we're not interested. You know, there may be a scenario where, based on like what Jim just said, looking at other data points, we may only be interested in drugs that are on the top 25 and not interested in detailed information on a drug that may have hit one of the triggers.
Another question, Representative Bleier, or are you all set? You're all set. Okay, and I do one of the things that I heard you say, Ms. Harrington, that I think is an important point is that when we negotiated some of this in the 129th, that the manufacturer specifically requested that we stick to Maine data and not use national data. Am I correct about that?
I think the pushback there was actually more from the PBM group. Manufacturers actually, in some cases, will have a more difficult time reporting Maine-based data because a lot of the larger manufacturers are working through wholesalers and don't necessarily know where the product ends up after the lots are sold to specific regional distribution centers that might cover several states, especially in the Northeast where the states tend to be smaller geographically. So in the case of manufacturers, we're still asking for national data. The PBMs, one of the associations for the PBMs requested that we retain the language specific to the state of Maine, and we understood their perspective, and so that we've pulled that back from our requested changes.
Thank you, Mr. Jones. Appreciate that commentary. And Representative Evans, please go ahead.
Thank you, Madam Chair. Mrs. Harrington, I would suspect that it would be more valuable to have information relative to the top 25 as opposed to just those that meet the trigger.
I don't disagree. I have wanted to focus on the top 25 reports because, again, I think those are the drugs that Mainers are using and we're spending money on. But I do think that it is interesting to look at what's also going on with the triggers.
Yeah.
So we do have, this is getting into the weeds, but we do have criteria that we've developed internally in terms of drugs need to hit our criteria before we go out and ask for the detailed information from the reporting entities. And the reason for that is because we're trying to focus. I don't want thousands of, I can't handle that. So again, just to put this in perspective, over 30,000 NDCs, we asked for less than, 200. And so one thought, just to throw out there, it is important to me that we are providing the information that you're all looking for from a policy perspective. So I think, to your point, Representative Evans, being able to access information from the manufacturers on the top 25 is critically important. And if the concern from the reporting entities is burden, then maybe put a cap in terms of how many NDCs and drug product families we can ask for. But give us the authority to go out and look at drugs that are part of the top 25.
Thank you.
You're muted, Madam Chair.
Darn it. Thank you. Senator Brenner, do you have a question or were you going to move to a motion?
I was moving to a motion.
Okay, before you do that, I have one other thing I'd just like to bring up for the committee to consider, and perhaps for you, Senator Brennan, if you're making the motion. In Ms. McCarthy Reed's analysis, she refers to in point 2, the definition of prescription drug, and that Community Health Options suggested that we clarify the language to refer to both dispensing and administering of a drug by prescription. I'm wondering if there's any issue with that with Ms. Harrington or Mr. Jones. And if not, is it the committee's sense that that's a good idea?
I would just say that if you do add administered, I would make it an or, dispensed or administered, so there's no ambiguity there. I have not heard across the states of any issues with the definition as it's currently written. There are varieties of definitions. I don't personally feel that the clarification is necessary. We haven't had any pushback, I would say. But if the clarification is warranted, then I would definitely include an or rather than an and.
Okay.
This is for 686.
686. Thank you. Yes. And Ms. McCarthy Reed, does the or work, you think?
Yes,
Okay.
that would work.
Any other thoughts from the committee about that suggested change? No. Okay. Please go ahead, Senator Brenner.
Thank you, Madam Chair. My intention was to make a motion for LD 41 first to pass.
Can I have a second, please? Yes, Representative Matheson seconds. Okay, the clerk will call the roll. I'm sorry, Representative Morris wants to say something. Go ahead,
Yes.
Morris.
Yep. Yes. Thank you, Madam Chair. We'd like to take a few minutes to caucus.
Okay. So
I'm going to suggest that we caucus this as well as take our lunch break, and we'll meet with Senator Jackson now, and then we can come back and vote LD 41 and LD 686 right after lunch. Does that make sense to everybody? Because Senator Jackson's available right now as well.
Great.
Yep, that's fine.
Okay, great.
Okay, so can you give us some timing here, Senator Sanborn? You're suggesting that we come back at 1 or 1:15?
Yeah, let's come back at 1:15 so that everybody gets a chance to eat as well as talk. And I think we'll be in good shape. And my apologies, my internet just came back on. I don't know what happened. Okay.
Technology.
We'll see you at 1:15.
See you all at 1:15. Thank you.
Darlene,
Yes.
can you put up one of those? Do you have, like piece of paper that will say the committee will be back at 1:15 that you can put up on
Don't.
YouTube?
I've
Oh,
never had to do it.
oh, geez. Let's see. Christian, you said probably has one. I don't know. Do you have access to his stuff?
Yeah,
can
but
do it.
I have no
I'll do
idea
it.
how to do it, Colleen.
I'll do it. I'll do it.
You'll do it? Okay,
I'll do it
'cause
for you. No problem. I can do that right now.
I feel bad, but
That's okay.
my committee don't
Fine.
caucus.
Yeah, I know. I know you guys have your act together. I'll do it.
Oh,
and
that's not true.
I'll see you at 1:15.
All right. Bye.
Bye.
going to be another minute. I need to get a glass of water. I will be right back. All right. Gonna wait for a few more members of the committee. Okay, all right. We've got a good number of committee members now. I'm going to ask Representative Morris, do you guys have any more questions for Mr. Jones or Ms. Harrington, or should I send them back through the wormhole? Can you guys hear me?
I can hear you. I don't believe we have any more questions. I don't know, Josh probably can't hear you. But I don't think, John Connor, you can, we don't have any more questions.
Okay, great. I'm going to push them back over to the attendee list. Oops, except I'm not a host, so I can't do it. Someone else can do it, or they can make me a host.
I'll do it.
Great. Yeah, thank you. Okay, perfect. Great, and Representative Tepler's with us. So when we took a break for lunch, there was a motion and a second for LD 41, which is major substantive rule of the Maine Health Data Organization. And is there any further discussion on the motion? All right, seeing no hands go up, we'll have the clerk call the roll.
Okay, Representative Quint. Okay, Representative. I know she can't do it online. Representative Connor.
No.
Representative Bleier.
No.
Representative Morris.
No.
Representative Matheson.
Yes.
Representative Evans.
Yes.
Representative Alford.
Yes.
Representative Mellorang.
Yes.
Go. Thank you. I had this written down too. Representative Brooks. Is she here? No, she's absent. Representative Senator Stewart. He's absent. Senator Brunner.
Yes.
Representative Tepler.
Yes.
And Senator Sanborn.
Yes. All right.
7 in favor, 3 in opposition, and 3 absent.
Thank you. What is the report for the minority?
I apologize. I was out of the room when you started talking. It's LD 41, I believe, still. Yes, we're ought to pass as amended, taking out references to the drug product family issue.
Okay. Colleen, is that enough guidance?
I think
Perfect.
so. Yes,
Great.
thanks.
Okay. And the second bill is LD 686. I'll entertain a motion. Representative Senator Brenner.
I will make the motion ought to pass.
Great. I think it's
Add the amendment.
amended. Yeah, it's been amended. So
Ought to pass as amended.
Great. Is there a second? All right, seconded by Representative Matheson. Is there any further discussion on LD 686? Representative Morris.
Thank you, Madam Chair. I'll be very brief. We will be opposing this motion as well. Our feeling is that this was something that was passed just 2 years ago. We think that we need to give that law time to work before we go passing new laws. So for those reasons, we will be opposing this motion.
Okay, I will just respond that this change was brought to us in light of writing the first report. And I, for one, was really disappointed with the inability to understand which drugs had actually had a price increase. I think that's really critical. And, you know, Mr. Jones is explaining that the only way for us to understand those price increases is to understand the context of the drug product family in which they happen. So I actually think that this is exactly how good policy gets made, which is that the folks who try to implement the policy that we made in 2019 came back to us and said, this doesn't quite work. We need this additional authority or this additional clarification or this additional tweak to the law. So I think that iterative process of lawmaking is exactly what's at work here, because we're not data collection experts, and Karen Lee Harrington and Jim Jones are. So I'm pleased to be supporting the language in LD 686. Is there any further discussion? All right, seeing none, clerk, call the roll.
Representative Quint, Representative Connor,
No.
Representative Blyer.
No.
Representative Morris,
No.
Representative Matheson,
Yes.
Representative Evans,
Yes.
Representative Alford,
Yes.
Representative Melarano,
Yes.
Representative Brooks,
Yes.
Senator Stewart, absent Senator Brenner,
Yes.
Representative Tupler,
Yes.
and Senator Sanborn. Oh. She froze up. Do you want me to wait for her to unfreeze?
Yeah, Senator Sanborn, you just froze. I don't know if you have disappeared completely. Senator Sanborn did lose internet earlier. I don't know if that's what's going on now. Oh dear.
All right, well, I've got 7 in favor of the motion, 3 in opposition, and 3 absent. And is the minority report ought to pass, ought not to pass?
Ought not to pass.
Ought not to pass.
Senator Sanborn just let us know that her power just went out again. So that is problematic, and I assume she'll get back to us when she can. Oh, she's
trying to get back on.
She's on her phone. All right. So, Senator Sanborn, would you like me to lead the meeting here now? Or are you all set on your telephone? It looks like she is in fact frozen again. All right, so do you want to go ahead, Darlene, and tell us what the vote was? I'm sorry.
Yeah, it was 1, 2, 3, 4, 5, 6, 7 in favor, 3 in opposition, and 3 absent.
Okay, thank you for that. And I assume that if Senator Sanborn can get back on, she will vote when she can, or she'll have to take charge of the absentee method of voting.
Oh, no, I'm good at grabbing you guys. As a matter of fact, Representative Brooks just hopped on, and if she'd like to vote on 41, I could get her now.
Okay, Representative Brooks, would you like to vote on LD 41?
And the motion
Yeah.
was ought to pass.
Ought to pass?
Yep.
Yes.
Okay, thank you.
Thank you, Representative Brooks. So I guess we will move on to our next set of work sessions. And Colleen, can you help me out here with which ones Senator Sanborn had identified as coming up next?
I think she had indicated that you were going to work LD 120 next, which was the bill to establish the Office of Affordable Healthcare. Does that sound right?
That does sound right, because we were able to get some work done on it over our lunch break. So please go ahead and present your analysis to us.
Sure. Maybe by the time I'm finished, we'll get Senator Sanborn back. This is LD 120. As it's drafted, it would establish the Office of Affordable Health Care within the legislature. The office, as drafted, would be charged with analyzing data using existing sources like the Maine Health Aid Organization and the Maine Quality Forum, and developing proposals for the Joint Standing Committee of the legislature having jurisdiction over health coverage matters on methods to improve the cost-efficient provision of high-quality health care to residents of Maine. The language requires the office to hold an annual public hearing on cost trends no later than October 1st annually. And the office is required to submit an annual report. It's established as an independent, nonpartisan staff office of the legislature to advise, to work with the legislative committee, but there's also the establishment of an advisory council to provide advice to the legislature and to the office on matters affecting healthcare costs in the state. As drafted, the language would comprise the advisory council of 8 appointed members, including members representing hospital interests, primary care provider interests, healthcare consumer advocacy organizations, health insurance interests, purchasers of healthcare, the healthcare workforce, interests of older residents of Maine, and a member with demonstrated expertise in healthcare delivery, healthcare management, or healthcare finance and administration. It does designate that the Commissioner of Staffs and the Commissioner of Health and Human Services would serve as ex officio members of the Advisory Council. This is a bill that reflects the final version of legislation that was considered by the HCIFS committee in the 129th legislature. That bill was LD 2110. That was ultimately voted out of the committee, ought to pass as amended, and LD 120 reflects that final amended version of the bill. It was enacted in the House and then referred to the special appropriations table in the Senate. Although it was carried over to any special session, the legislature did not reconvene, and final action on the bill was not taken up before termination of the 129th legislature. I did share a suggested revised amendment from the bill's sponsor yesterday, making 2 suggested changes to the language. One, putting in place a provision that the office use definitions and methodology that are currently in place and used by what's called the Healthcare Payment Learning Action Network in its work evaluating healthcare costs. And then also a suggestion to add 3 additional positions to the advisory council, a member representing behavioral health interests and 2 members with expertise in health economics and research, 1 each that would be appointed by the president and the speaker. Some of the issues that were raised at the public hearing include whether or not the duties of the office might duplicate efforts of other state agencies in certain areas. For instance, one of the duties is that the office would monitor alternative payment models, and we've heard before about the ongoing work of both the Department of Health and Human Services and the Maine Quality Forum on alternative payment models. The language also would ask the office to develop or consumer assistance programs for areas that are not currently addressed by programs in the Bureau of Insurance and through the contract with Consumers for Affordable Healthcare to provide a consumer assistance program. One of the issues related to the public hearing that's required to be conducted annually in the bill. It was suggested that the committee consider changing the hearing date from no later than October 1 annually to no later than November 1. So it does not overlap with similar hearing to be held in Massachusetts. You might recall that one of the that came up at the public hearing, and for members of the committee that have served before, this bill is modeled in part on a Massachusetts law, and as a part of that legislation, the Massachusetts Health Policy Commission does their annual report also no later than October 1 annually. So it was suggested that the committee might consider moving the date of the annual hearing here. Lastly, I guess I would just raise issues related to the structure and placement of the office as it's drafted. As I mentioned, it's established within the legislature. There are other options for the committee to consider. Establishing it within an existing state agency, for instance, or as an independent executive commission or agency. One of the issues related to how the language is drafted, and we discussed this somewhat last session, is it appropriate for a legislative nonpartisan office to develop proposals and make recommendations? And if you move forward, you may want to clarify that. Then one of the other issues is the language as drafted designates the legislative office as the staff for the executive branch main prescription drug affordability board, and just the consideration of those types of issues in terms of overlapping responsibilities and authority of the legislature and the executive branch. And then lastly, because it does impact, as it's originally drafted, legislative operations in the budget, it is anticipated that the proposal would be further reviewed by the Legislative Council, either as part of the study table or the special appropriations table process, as funding will be needed. And the preliminary fiscal impact statement has been provided by the Office of Fiscal and Program Review, and this updates the fiscal note that was on the previous legislation I mentioned, which is LD 20. It would require general fund appropriations to provide funding for the costs of, as it's laid out now, it's anticipated initial funding for the cost of one director position, one legislative analyst position, and one administrative secretary position within the office, and additional startup costs. It is assumed that because it's drafted as a legislative office, it would be located in state-owned space, so there would not be any additional rental costs. And then any additional costs to absorb for members of the executive branch to serve as on the advisory council are expected to be minor. I'm happy to stop there and answer any questions. I can also pull up the proposed amendment if you are interested in seeing that was shared yesterday by the president's staff.
Representative Tepler.
Thank you, Madam Chair. And I am going to say that I felt that a very fruitful conversation was had with the sponsor during our lunch break, and that I believe that some members of the committee would like to entertain some additional changes to the amendment. I don't know if I should talk about those or somebody else wants to. Senator Brenner, I think, would like to talk about them. So I will
Brenner, go ahead.
Defer to her.
Thank you, Madams Chairs. I'm not sure which one of you is our Madam Chair right now, but
teaming. It's all right. Go ahead, Senator Brenner.
I think what we would love to do is address Colleen's thoughts around the idea of it being a legislative office and perhaps create it outside of the legislature, and make sure that it has an executive director that's appointed by the governor for a 5-year term so that it overlaps with different administrations. So that's 2 changes, I guess, right? And then let's see what I have in the little list here. So So it's an independent agency. It has its executive director, and then the advisory board would stay the same as set forth in already in 120. So those would be the two amendments.
Representative Tepler, go ahead.
Thank you. As set forth in the amendment to 120, I believe, with the 13-member advisory board.
Yeah, exactly.
And I also, I think we discussed and agreed that we'd like to add a section in the duties section that includes a systemic approach to health policy and systems analysis.
We can wordsmith that at some point.
Sure.
So I want to speak to the logic here of why we're balking a little bit and making this a legislative office. So one of the things that we keep hitting upon, I think, is not having the capacity or the jurisdiction really of anyone whose job it specifically is within our state government to think every day about affordable healthcare, about the affordability, about cost containment, about things like access to affordable medicines. There's just no single person or single organization that you can go to that has that oversight or that authority. And so when we look at a program like the one that's coming up next, the insulin, the emergency insulin program, that's a consumer assistance program that doesn't exist today in Maine. And then we have to try and figure out where to put it. And, the decision was made to put it in the Board of Pharmacy. And I think that's okay as a temporary measure, but it's really not what boards of licensure are for, right? What we really need is some sort of organization that can administer all the different aspects of affordability and of healthcare policy going forward. And the Prescription Drug Affordability Board, I would suggest we actually amend LD 120 to make clear that the Prescription Drug Affordability Board is now under the Office of Affordable Healthcare. It's like an entity under that umbrella. So we can amend LD 120 to say that, and then we would have staffing for the Prescription Drug Affordability Board, which has been tricky. We're borrowing staffing from the state employee health plan, I think, in order to make it work right now. But again, it means there's nobody really focused on that mission because everybody's job is to do something else. We try to focus on that mission here in this committee, but we're basically volunteer part-time legislators without a healthcare background or a health policy background. Some of us have a healthcare background for sure. I didn't mean to imply that, but I think it makes it very difficult for us to have that continuity and that ability to really make good policy and do good analysis. So we've talked about that before. But the more we got close to passing LD 120 in this form, I just grew very uncomfortable with the fact that it would be so limited in what it could do, to basically being like a super duper Colleen that can just advise us in a nonpartisan way. Like I want them to be able to do things like administer, an insulin program, emergency insulin program, or determine if excessive prices have been charged and then, report that to the Attorney General. Those types of things just really require an office that has independent authority, independent of the legislature. So this is why we landed on this particular structure for the office. So I'll stop there and see if there's further comments. All right, I will also just make another comment then, which is that this does have a fiscal note. It has the general fund fiscal note. It'll have to be redone because it'll be a slightly different, salary table, because it would not be a legislative staffing salary table, but there's equivalents that we'll use in state government. But again, thinking about the quantity of issues that this committee deals with every day and every year, and the ways that we're trying to really wrap our heads around cost containment, around things like, I mean, another great example would be the primary care spend bill that we need to come back to next year, right? How do we incentivize primary care spending instead of emergency care after the fact, et cetera? So Representative Zager's bill, I mean, all of these things really are going to require some kind of structure and administrative support. And the Bureau of Insurance is just not always the right place, and neither is the Department of Health and Human Services, which has a really enormous role aside from affordability of healthcare. I think that fiscal note is really money well spent. I think it's going to pay itself back, not literally, but in terms of savings for Mainers many times over. And if we're not willing to invest in trying to have someone really keeping an eye on what's going on with affordability, then I think we're not really committed to the goal of driving down costs, making healthcare truly accessible and affordable for everyone in the state. So I really hope that this becomes a spending priority. I know it'll be my #1 table priority, hands down, if we get this bill onto the table. So just wanted to speak to that piece of it as well. Representative Tepler.
Thank you, Madam Chair. And I agree. And I was very concerned about the limitations that are created by having nonpartisan staff as the staff for this entity, because nonpartisan staff have to be very, very cautious about taking positions. We know this. We know that Colleen serves us all, regardless of our party, and that she's very, very cautious about the way she takes positions, and she acts in a totally professional manner for her role. And that role may not be the right role for an executive director of an Office of Healthcare Policy. So that's where I come down on it, and I am very happy at the idea that the state might have an independent entity looking out for Mainer's healthcare costs. And I feel like people have been asking us for something like that for quite some time, that healthcare has risen to the top of the list of our constituents repeatedly, and that this is one way we can begin to get at it. Thank you.
I'll just draw a comparison to the Office of the Public Advocate within the energy realm that's always looking out for ratepayers, and that's really critical. And so I think it's just super important that we put this structure back in place, frankly, on the healthcare side, which is such a huge part of our economy. Okay, is there any further discussion? Representative Arford, go ahead.
Yeah, I thank you so much, Madam Chair. And I think this is an exciting piece of legislation that has true potential. However, we need to, I just want to make a note that the people that are the majority of the people that are being appointed to the advisory committee are people who represent the industry. It would be like the PUC being represented by members of CMP. I mean, the point here is, I'm just going to say one final time, I would like to see more than one consumer entity on the advisory group representing the interests of patients and healthcare consumers, because right now, the way that it sits, there is just one.
Fair. Representative Morris?
Thank you, Madam Chair. I have, a lot of concerns about adding another bureaucracy within state government. I think in particular, we have heard repeatedly what the issues are with costs in healthcare. We have our side has brought forward bills to try and deal with that issue, and consistently the majority on this committee has opposed those ideas. So for those reasons, I just think, again, all this is going to do is add another layer of bureaucracy into state government. I'm not convinced it's going to do enough to really attack the underlying issues, because I just don't think it will. I'm not convinced that adding another bureaucracy to study this issue is going to help. So for those reasons, I will not be supporting this bill.
Representative Connor.
Thank you, Madam Chair. I too, when I ran on 3 different items, but 2 of them were helping our healthcare system become more affordable and limiting the size of government. So as you can imagine, I am torn on this bill, but I agree with Representative Morris. I think there are other methodologies to going about this, and I just don't think an added office in state government is what we need right now. So I will also be opposing this.
Representative Tepler.
Thank you, Madam Chair. And I want to be very clear that the disagreement between the other side of the aisle and myself is about what creates lower costs. It's not a vote against proven lower costs. It may be a vote against a particular ideology in lowering costs. And I think that the good representative impugned the character of some of his colleagues a bit.
Not at all. Not at all.
Statement indicating that we had voted against lowering healthcare costs for Mainers. I don't believe that that's true, and I certainly will continue to work to lower healthcare costs for Mainers.
Representative Morris.
Thank you, Madam Chair. I did not impugn anybody's character. I merely pointed out the voting record on bills that we have sponsored, that we have supported, or bills that we have opposed that we feel might have added costs to the system. There was no intention on my part to impugn anybody. Everyone has their ideas about what's important in healthcare, but I will say, when you add costs like mandates into the system, when you add mandates onto insurance companies that only work for a small group of people, and I know this isn't necessarily germane to this particular bill, it does have an effect of raising costs. And I don't know that this bill, this specific thing, is going to get at the heart of some of these issues. So that's.
Thank you, Representative Morris. Senator Brenner.
Thank you, Madam Chair. I co-sponsored this bill because I feel like it's an incredibly important component as a partner to the Maine Health Data Organization, for us to be able to take all that data that this committee was so thoughtful about asking for over the years, and being able to analyze it and not have it be influenced by all of the parties whose profits are motivated by the work of our committee. You know, we work on this like 4-legged stool. We have the hospital association, we have the providers, we have the pharmaceutical companies, and we have the insurance companies. And every day we're sitting here and we're trying to kick somebody's leg out from underneath them to try to some leg of the stool, right? And there's always complaints. And the beauty of the proposal here is that we have the capacity to have an independent third party organization that can take the data that we're collecting, synthesize it, and feed it back to us with appropriate policy ideas that can help to lower costs for Mainers. So I feel like this is exactly what we've been waiting for, is the next layer of the work that we need to do to be able to use the data that we're collecting. It doesn't make sense for us to collect the data if we're not going to use it. So I'm excited to support this. I feel really good about the amendments that we've put into place, and I'm looking forward to voting for it.
Senator Brenner. And I wanted to just not let the comment go that we consistently vote against proposals that would lower costs for Mainers. And I'll use the example of the mandate for that Representative Morris brought up, or of insurance mandates in general. Voting against insurance mandates doesn't lower costs. All it does is to deny care. It makes it so that folks who can pay out of pocket, for example, for fertility treatments, have access to that type of healthcare, and people who cannot pay out of pocket for their hearing aids do not have access to it, just to use two different mandates that we have passed in, or that we are considering in the past. So, you know, affordability is really a really complex issue, but denying access isn't a way to make things cheaper. And so affordability is a complex issue that this committee always takes into account. I think, and simply making sure that people can't access things like dental care is probably not the same as making dental care affordable. Representative Morris.
Yes, thank you, Madam Chair. I just would say I did support the hearing aid bill last session, as it was a unanimous report. But I also got calls from constituents because they worked for a company that they were not able to get that because they were not on a state regulated plan. So we can say we're denying care, but if we're only passing something that applies to 25% of the market, and those are the people that are like myself in a position where they're buying through an individual market, which is regulated by our state, by our Bureau of Insurance, it drives up the costs for those folks to pay for any new mandates. That was my only point on the mandate section, on the mandate point. I understand it certainly helps with care, and I think as someone who has a family history of hearing loss, I certainly am well aware that at some point I may require what we passed in that bill. But I also am well aware it was also disheartening to get calls from constituents that thought they were going to get their hearing aids covered. And it turns out they weren't, because they weren't on a plan that was regulated. That was my point on that. But in the meantime, it also does raise the rates, because it has to be reflected in rates, any mandated coverages. That was my only point on that.
Yeah, no, I understand and I appreciate it. I know you're actually coming from a place where it was not meant to, you know, cast aspersions, but I couldn't let the pitch sail by because of how much work we as a committee do. And frankly, we do it in a unanimous fashion quite often. If we find something that we think is going to save Mainers money, we usually vote for it unanimously. So I just wanted to, it was a very partisan comment. So I just wanted to make sure that we did have a chance to talk about it a little bit. And I think we can let it go there because we've done some great work on this committee, including on prescription drugs within the last couple of years, while you, Representative Morris, myself, Representative Blyer, Representative Melrano, Representative Brooks, Representative Tepler have all been on the committee together and doing some great work together. So I hope that can continue. Is there any further discussion on the bill? Let's bring it back to the bill, which is LD 120. And we've been discussing a proposed amendment to the structure of the office. Any further discussion? Okay. So I am going to move ought to pass as amended. We are going to have some significant language review work to do on this bill. But Colleen has assured me that is fine. We talked over lunch as well, and she'll be able to draft something to reflect our discussion today. Senator Brenner, did you want a second?
Yes, please.
Great. Is there any further discussion on the motion? All right, seeing none, the clerk will call the roll.
Representative Quinn, who can't contact us. Representative Khanna?
No.
Representative Blyer?
No.
Representative Morris?
No.
Representative Matheson?
Yes.
Representative Evans?
Yes.
Representative Alford?
Yes.
Representative Melrano?
Yes.
Is that a yes?
Yes. Yeah.
Okay. Representative Brooks,
Yes.
Senator Stewart, is absent. Senator Brenner,
Yes.
Representative Tepler,
Yes.
and Senator Sanborn.
Yes.
8 in favor, 3 in opposition, and 2 absent. And the opposition is that ought not to pass?
Yes.
Great. Okay. The next bill that we're going to bring up is LD 749, which is related to LD 120, which is why we're bringing it up right now, in that it would establish a council on health systems development. And I'm going to move ought not to pass because I think we're going to move things around a little bit with LD 120 and moving the Office of the Prescription Drug Affordability Board into that. And I think the Council on Health Systems Development could potentially be something that the Office of Healthcare Affordability looks into reestablishing down the road a piece as they grow and build capacity, if that's a helpful project for them to undertake. So I will move ought not to pass. Is there a second? Representative Tepler has seconded the ought not to pass motion. And is there any further discussion? All right, seeing none. So Representative Perry is the sponsor of the bill, and it is a courtesy. I'm going to bring her in. She has her hand up. Representative Perry, you can go ahead.
Yes, thank you. First of all, I want to thank you for all the hard work in doing the bill previously, because I think that's the way that it should go. The only thing that I would ask, and I'm just wondering if it is possible, some of the duties that were listed in my bill, would it be possible, if everything goes through, that we send a letter to the new Legislative Council to really look at that as sometimes the beginning points? I think the one thing that I've looked at is that we have a healthcare system that is very inefficient, and efficiency and quality will also help lower costs. And I think we need to take a hard look at taking our healthcare out of silos and getting them to work together. I think that the 120 bill will do that. I want to thank you for your work on that, and just ask that.
Yeah, so I think Representative Perry, the way that we had attempted, and Representative Tepler spoke about it earlier, and it's intended to be included in the motion that we just voted on, was to amend the duties to make an explicit reference in the duties of the Office of Affordable Healthcare to a systems approach to healthcare. And so that was intended to sort of crib some language from your bill and insert it into the Office of Affordable Healthcare as part of the way that they would approach their work. Does that make sense?
Yes, thank you.
Yeah. And it was early on in our discussion, so I think it might have flown by a little bit, but it is intended to be a part of the amendment that we just voted on. I think it addresses your concern.
And thank you for your work.
Absolutely. Representative Arford, go ahead.
Thank you, Madam Chair. I would just like to quickly acknowledge the work that Representative Perry did on this bill. I have spoken to her about it. She spoke, she has worked extremely hard for a number of years of bringing this type of legislation forward that addresses healthcare issues from a systemic perspective. And I'm confident that that's where we're headed. But I just really wanted to acknowledge Representative Perry. And I also wanted to state that we do have, I agree with Senator Brenner's earlier comments about the four touch points, the 4 legs of the healthcare system, except for there's actually a 5th leg, and that's patients and healthcare consumers. And they are so often left out of the conversation in meaningful and equitable ways. And I'm confident that our committee understands this, and that we will include them and bring them along in this bill when we do the language, the next step. So thank you very much, Representative Perry.
All right, thanks.
Representative Arford. Okay. Is there any further discussion about LD 749? All right, I want to thank the sponsor so much for joining us and for bringing us this important perspective as well. And I'm going to send you back through the wormhole before we vote here, Representative Perry. Okay. So I see no further discussion, so the clerk can call the roll.
Representative Quint, Representative Connor,
Yes.
Representative Blyer,
Yes.
Representative Morris,
Yes.
Representative Matheson,
Yes.
Representative Evans,
Yes.
Representative Arford,
Yes.
Representative Melorano,
Yes.
Representative Brooks,
Yes.
Senator Stewart, absent, Senator Brenner,
Yes.
Representative Tupler,
Yes.
and Senator Sanborn.
Yes.
11 in favor and 2 absent.
Thank you. Okay, the next bill that we're going to pick up is LD 673, an act to create the insulin safety net program. And I'm going to have Colleen do her analysis on this one. You can go ahead, Colleen.
Here is LD 673. As Senator Sanborn said, the bill would establish the insulin safety net program. It's modeled after a similar bill and program that has been established in Minnesota. It would direct the Maine Board of Pharmacy to oversee the program. And as drafted, it would require that by January 1 of 2022, manufacturers of insulin establish procedures to make insulin available to pharmacies for dispensing to eligible individuals who are in urgent need of insulin or who need access to an affordable insulin supply. And the bill would provide 2 ways to access insulin under the program. One, to reflect the urgent need, would authorize the dispensing of a 30-day supply by a pharmacy to an eligible individual. And secondly, for those demonstrating a continuing need, based on criteria established in the bill, they would be provided access and dispensing of a 90-day supply of insulin. The language of the bill requires annual reporting to the legislature by the Board of Pharmacy on the number of residents that are accessing the program and the cost to manufacturers. And as drafted, the bill is sunset, so it would be repealed in 5 years. So it would be 2027, January 1 of 2027 is the repeal date as the bill is drafted. Just to remind you, when we've discussed these before, the committee did take some action in the last legislative session related to access to insulin. Current law does authorize a pharmacist to dispense emergency refills of insulin and associated insulin related supplies, and requires that the amount of insulin dispensed be in a quantity that's the lesser of a 30-day supply in the smallest available package. And Representative Tepler sponsored a bill this session, LD 60, to clarify that current law. And then secondly, there are provisions in the insurance code now that prohibit health insurance carriers from imposing a cost sharing requirement for prescription insulin drugs in excess of $35 per prescription for a 30-day supply of insulin. As LD 673 is drafted, it would provide coverage for folks no matter what their health insurance status is or the coverage that they have provided. So the eligibility, it's much broader than what is available under the current law.
Colleen, can I stop you there for a sec? Because there's a lot of issues that we're going to discuss. So I want to maybe stop and discuss this piece first.
Oh, sure. Yep. Because stop sharing. I'll go back.
No, I think it's fine if you keep sharing. I just wanted to sort of ask a question with regard to the coverage of the bill. I think the bill doesn't actually apply if you have a plan that has a $35 copay. So I think you have to have a copay of more than $75 in order for this whole thing to kick in, or you have to be uninsured and not eligible for main care. And just speaking to kind of Representative Morris's comment in the last hearing or in the last discussion, you know, our insulin bill that we passed last year that capped copays at $35 for individuals, and I think that might have passed unanimously as well. We can only cover, you know, we can only regulate the plans that we can regulate. So it doesn't apply to large employer self-insured plans. They can charge whatever they want for insulin copays still. So I just wanted to point out that this bill kind of like fills in a gap where we weren't able to cover those folks with the $35 law, but we can at least give them this emergency support or urgent support if they're in that place where their copays are unaffordable for their insulin because of the type of plan that they have. So I wanted to point out how the bills work together because they don't overlap. They actually have like a really nice kind of jigsaw fitting together of them. Colleen, have I said that right about the $75? I think it's $75.
Yes, yeah, the to qualify for the urgent need, which is the 30-day supply of insulin, the eligibility category, I mean, you must be a resident of the state, not enrolled in main care or other coverage that limits the total amount of cost sharing that someone's required to pay for a 30-day supply to $75 or less, regardless of the type of the amount of insulin. And then there's also a limitation that the person has not received an urgent supply of urgent needs supply through the program within the previous 12 months. So there are further limitations about how many times an individual can access the program.
Right. And then in terms of fitting in with the emergency dispensing law that we passed last year, that emergency dispensing law is silent as to how the insulin gets paid for, right? It's just that you can dispense on an expired prescription under certain circumstances.
Yes, under the existing provisions, that's how I read that.
Okay, so again, like piece of the jigsaw, they don't overlap. They're just all kind of fitting in to try and buttress the whole thing.
Yeah, and I think this would provide, well, it would provide the ability for the pharmacy, you know, for that to be done without, you know, without regard to insurance, I guess, if you will, as opposed to what's happening in the on the existing provisions of the 30-day supply. Presumably, there'd be an option for that to be billed if the individual had insurance.
Right, and I think that
still,
right. I think that would still exist, and then this would be a way of paying for it if they don't have a way of paying for it.
And this would provide the would require the manufacturers to provide it and essentially pay for it if there wasn't that additional coverage.
Okay,
that's how I read it anyway.
That's how I read it too. I just wanted to be clear about that because I had some questions in talking with different folks about why we were doing another thing with insulin, because there's like a big donut hole, I think, that we're trying to help people with. And in part because of our reach with regulating insurance plans is not 100% of insurance plans in particular. Okay, Colleen, you can go back to screen sharing. I'm sorry to interrupt your analysis.
No problem. Good discussion to have. Okay. I did want to note that I did share an amendment with some yesterday with some additional language suggested by the sponsor that would add a provision establishing an annual registration fee of $75,000 per year to be paid by an insulin manufacturer to the Board of Pharmacy to help support the program, except that a manufacturer that does not sell or distribute $500,000 or more units of insulin within the state in the year in which a registration fee is due would not be subject to the fee. This provision would also be sunset like the other provisions in the bill after 5 years. So that's the only suggested sponsor amendment that I am aware of to the bill as drafted at the moment. You did, however, get some additional information that was suggested from the Office of Professional and Occupational Regulation, and I laid out a number of sort of technical questions and suggestions that they've made to the bill. I'm happy to go forward, but is there a hand there? So I'm happy to stop too if there's a hand.
Representative Tepler, go ahead. You don't have to stop sharing though. I can see Representative Tepler's
Okay,
hand.
perfect.
Yeah.
Thank you. Thanks. And I just was going to ask about the manufacturers and the amount of insulin that they sell in the state. And sort of, I guess I just don't have a clue how many manufacturers sell over that amount in Maine. I mean, maybe that's information that would be helpful to have, why that number was chosen. I don't know if the sponsor is here.
I don't think she is, but let me look. I don't see the sponsor. And I don't know who else could give us information on that.
Yeah.
But I know that there are only basically 3 manufacturers of insulin in the country, so it's pretty concentrated. I think the vast majority of it is sold by 1 manufacturer or 2 manufacturers.
Okay.
So I had that same question. I feel like we asked that question at the public hearing, but we have not received information back on it. I would anticipate, because of the concentration here, that it's going to hit the manufacturers that sell and just, sell insulin, because there's really only a couple.
Okay, thank you.
Colleen, do you want to walk us through these technical amendments?
I'm happy to. I just sort of tried to bullet point them quickly for the purposes of the analysis. And I know that Ms. Cohen is here from the Office of Professional and Occupational Regulation if you have specific questions about the suggestions. But one of them was thinking about an extension of the effective date to provide some additional time for the Board of Pharmacy to work on implementation, suggested either February or March of 2022. Let me just go through them all or take them up one by one, Senator Sanborn?
I guess let's take them up one by one. Is there any response from the committee on moving the effective date? That seemed reasonable to me. I can't see everyone's faces, but I guess if you would object to this change, raise your hand. I guess we'll do it that way. Raise your electronic hand. All right, I'm not seeing any hands go up on that particular issue, so let's move on.
Okay. The next one was a suggestion that instead of having the board authorize a pharmacy to dispense the supply, suggesting to cross-reference the law that we just talked about on the minimum amount of emergency refills of insulin, which provides authorization to a pharmacy to dispense that amount of insulin on an emergency basis.
That makes sense, I think, as a way of clarifying that.
Okay, great. And the next one was really a question, I think, asking about the situation when an individual might complete an application but doesn't have a valid prescription or relationship with a provider. What should the pharmacy do in those circumstances? And so I don't know if there's any thoughts on that, about whether that would be permitted.
I think that's last year's law that specifies the conditions under which a pharmacist can go ahead and dispense on an expired prescription.
Yeah, well, there is language in the bill as drafted that requires that in addition to completing the application, an individual shall also present to a pharmacy a valid insulin prescription and identification indicating residency. So I guess that's a question.
I guess that makes sense, right? We might want to have 2 ways of
yeah,
right? Either the individual qualifies for emergency dispensing under our existing statute that we passed last year, or they qualify by having a valid prescription.
Yep.
So we add like an exception there if they don't have a valid prescription, but they do qualify under the other law.
Yep. Okay.
All right, Representative Evans, go ahead.
Yeah, I just wanted to weigh in on the previous law and the current law. They are limited in the number of prescriptions they can have. I think is it twice a year, because these people need to be followed on a regular basis. So I suspect that if it's a limitation and they have to have a valid prescription, they're going to make some arrangements. So okay, you can go on.
Okay, yeah, I think we've addressed this. Representative Tepler, do you need to say something else?
I just wanted to point out that it would be very rare for a type 1 diabetic to not have some kind of prescription history for insulin, because they would be dead. So I guess I just don't see it being a major problem.
Yeah. Representative Evans, is that a new hand?
Yeah, it's not just type 1. The type 2 diabetics also use insulin.
Yeah.
So,
Okay. I think the cross-reference here makes this question go away.
I think so.
Or if we add a cross-reference, and Colleen thinks so too. Okay, great. Thank you.
The next one is there's current language in the bill as drafted that requires each pharmacy to provide an information sheet developed by the board with contact information related to their options, either for the program or for health coverage through Main Care, the marketplace, and other entities, and also information about how to access if any manufacturers have specific patient assistant programs. So the suggestion here, as I understand it, is that the board would like to be able to have another state agency or a contractor develop this information document for the board.
Yeah, Colleen, I know that Cake would be able to just, I mean, it's, quick and easy, sort of have their phone number as a guidance kind of thing. But I wonder if there's any place in our statute where we reference having Cake's phone number sort of suffice for this.
We did, I think it was Representative Arford's bill that we talked about earlier this session that dealt with notice and the notices that are provided to people when their coverage is terminated. And I believe we added language there for contact information for the Consumer Assistance Program. And that might be look at that similar language and replace it here with just providing that contact information, because I think they would certainly have all the information available as to how to access existing healthcare coverage options. The question, I guess, would be the extent to which they would be able to provide information on how to access, specific insulin manufacturer patient assistance programs. But
okay. I think that's the direction to go in, is to just borrow that language about a phone number for the Consumer Assistance Program.
Yep. Great.
And
okay. We can work on that later.
We can work on that language if we have. Yeah, exactly. And I can catch up with, or we can ask Cake if they have information about manufacturer-based programs or not. I don't know if they have that information or not. I suspect they may. Okay.
The next suggested change just relates to the language in the legislation that refers to reporting and auditing purposes, and the concern that it might imply sort of active auditing of the program. And the board suggested amending the language for reporting and compliance purposes, and that this is a requirement that requires the pharmacy to retain copies of the applications that are submitted by individuals. So just making sure that that's available to the board if necessary for reporting and compliance.
That makes sense to me. That's an easy change, I think.
Yep. And then the next is a suggestion really related to kind of a wordsmithing, I think. And they suggested deleting a reference in 13.725 subsection 4 to requirements to the program. And you see the strikeout is really shown here and copied for you. So it would just strike out that beginning of the first clause of the sentence related to manufacturers having their own patient assistance programs. And they didn't want any implication that the board might set those requirements.
I think that's fine. All right.
Okay. And real quickly, I think there are a few, let's see, there's a few more on the next page. And then again, this is the same issue maybe that we just talked about. Instead of manufacturers providing the required information about their patient assistance program to the board, they recommended amending the bill to require the manufacturer to provide that information to the agency or contractor like Consumers for Affordable Healthcare, so they could develop that information. So perhaps we could amend to ask the manufacturers to provide contact information to CAIC that could then for the consumer assistance program, and then they could provide it to the enrollees. That makes sense as this closes that circle, I guess.
Yep.
And then this next one relates to an appeals process, and as the bill is drafted, it would designate 3 board members to act as an appeal panel. And the Board of Pharmacy has raised that poses challenges for the board since it's a sort of volunteer limited number of board members available. So they suggested some options for the committee to consider as an alternative to 3 members of the board serving as the appeal process. In terms of the timing of the appeal, there are some deadlines set forth in the bill, and they've suggested perhaps changing the language that would happen at the board's regularly scheduled meetings. The board does meet about once a month, except for July and December that they've suggested. So the next regularly scheduled board meeting may work as an alternative. And then in terms of putting in place an alternative to the board serving as the appeal panel, perhaps the AG's office or the administrator of the Board of Pharmacy in consultation with an individual board member. While that's not how the language in Minnesota was handled, I think the Board of Pharmacy has had some discussions with their counterparts in Minnesota, and they handled the one appeal so far administratively and did not use the full 3-member panel. So that was a suggestion from the board.
So this is a circumstance where manufacturer determines an individual isn't eligible, I think is the situation.
Yes.
And, I would suggest the board administrator option in consultation with a board member seems like it makes perfect sense to me.
Yep.
It's going to be sort of on the face of the paperwork, whether they're eligible or not. It's numerical, I think.
I would agree with that.
And maybe documentation. Yeah. Okay.
Right. And maybe a documentation issue or a misunderstanding of the main program. And then we just tell the manufacturer they have to say yes or something like that. And that's fine.
Okay, great. And then the last suggestion relates to dissemination of information about the program. The language of the bill as drafted would direct the board to develop information that would be provided on its website and a link to that information that can be used by entities like pharmacies, healthcare practitioners, hospitals, urgent care clinics, and community care clinics about the program. And they've suggested perhaps having Consumers for Affordable Healthcare or some other entity develop this information on behalf of the board.
Okay. I did receive information from Ms. Endy that their helpline does refer people to prescription drug assistance programs. So they could definitely help direct people to manufacturer assistance programs if the manufacturers give us information particularly. So this actually, that provision could really help consumers for affordable healthcare in maintaining up-to-date information about what the manufacturers have available. But as far as this last provision here about dissemination of information about the program, I mean, I think we want to figure out how to at least get this information up on the website. I'm not and develop the application. I'm not sure it's very complicated. I might be wrong. Let's have Ms. Cohen come in and speak to that piece because I'm a little puzzled by it. So I'm going to bring her in.
I mean, one option might be, instead of saying the board shall develop the information sheet, maybe the board shall consult with Consumers for Affordable Healthcare, or you know, authorize them to consult with other entities to assist them in doing that.
Sure.
Perhaps that might help. I don't know.
That might make sense. Ms. Cohen, does that address the concern?
I am sorry, I did not hear what was
Sure.
said while I was going through the wormhole.
Yeah, no problem. So Colleen suggested that rather than having the board develop the agency, they would develop the brochure, they would consult with Consumers for Affordable Healthcare or with the Consumer Assistance Agency to develop the information.
Yeah, we are fine developing the application. And in fact, I think that makes sense for us to develop the application. We are also very happy to put it on our website, or a link to it, an appropriate link to it in a prominent place on our website. I would just want to make sure that if there's language about developing and consultation, that we are not the ones developing, but we are the ones consulting with while they're developing, because they really have far more expertise in the range of information that we were talking about that was raised at various points throughout this bill.
Okay. I think this section just talks about the dissemination of information about the program, just like an overview of the program.
Mm-hmm.
I'm just worried because I can't really order the Consumer Assistance Program to do anything in statute. They're not a state agency.
Mm-hmm.
So I could tell you to consult with them, and they've just texted me and said they're happy to consult with you on it, but I can't tell them to do it. Does that make sense?
Yep.
Okay.
Yep.
Okay.
Dissemination might be a better word, as you mentioned.
Right. Yeah, I think it's the development of the thing that gets disseminated that is questionable. And what about disseminating it to the pharmacists? I think you guys are okay with that. Is that right?
Yeah, no problem disseminating it to our licensees. Disseminating to others would be challenging.
Sure. Yep. And that's where Cake has their expertise as well. Okay, great. I think we can get there. Colleen, does that sort that piece out? Yeah. Okay, super. Okay. Keep going, Colleen.
Okay, and I think the last suggestion, as I understand it from the board, is to add a cross-reference in their enforcement section to provide authority to take any action if there's a violation of these provisions. So,
okay.
That simply would add a cross-reference to the existing enforcement statute.
Is there another page?
Oh, yeah. I'm done with that. I just,
okay.
Is it okay with that? Okay, yeah.
Ms. Cohen, you can go ahead.
Yes, thank you so much. I know this is the end of what we sent yesterday, but I did want to alert the committee and Colleen to the fact that we just forwarded some information on the sponsors amendment, which actually I haven't looked at. Some concerns that were shared by one of our by our board chairs. So I cannot speak intelligently and all on it since I haven't looked at it, but I just wanted to give you a heads up that we sent that in.
I haven't received it. Do you know where it was?
It was sent to Colleen.
Okay.
Thank you. Thank you very much.
Mm-hmm.
Does it show? I'm trying to share it. Is it working?
No.
No. Okay. I can't do it then. Okay. Sorry. I can't do it. I'll try to, it's in an email and I'm going to forward it right now to the committee.
Okay. That's great. And then can you just show, I'm so curious what's on the last page.
Yeah, no, I will. Hold on. I don't think there's anything on the last page. But let me do
The
this.
fiscal information must be there, right? Is there fiscal information?
Yes, there is fiscal information. So let me pull it up. All right. Go back. 17. I think everybody can hear me now. Well, two last concerns I think that were raised at the public hearing related to this. You know, we've talked a little bit about the fact that manufacturers have some existing financial assistance programs, although I think this is meant to sort of coordinate with those, but there was a question about whether it is duplicative. And then there were some concerns raised in written testimony that the proposal may violate the takings clause because it would require manufacturers to provide insulin at no cost. I did want to note that there was a legal challenge to the Minnesota law on this issue. It was dismissed on summary judgment grounds in March, primarily related to standing, so not necessarily on the merits. And so the court decision did suggest that there might be options for these entities to pursue takings issues in state court. And so I don't have any information about whether that federal district court decision was appealed or whether they're pursuing those claims in state court, but I wanted to make you aware of that. And then we did get a preliminary fiscal impact statement from the Board of Pharmacy on the bill LD 673 as originally drafted, indicating a need to allocate funding for an additional position within the Board of Pharmacy and any additional per diem costs for the board to serve as a panel. But I think we've maybe addressed that in the language we've discussed. And it did indicate that the Board of Pharmacy does currently have sufficient resources available to support the cost of this legislation without raising fees right now, but there may be a potential for additional fees needed in the future. And so I think I'll stop there, but I would note with the impact statement or the fiscal impact, if the committee moves forward with an amendment, there'll be an additional review of the amendment by the Office of Fiscal and Program Review with input from the Board of Pharmacy about whether there are any updates or changes to the fiscal impact statement as a result of any amendments.
And I think Ms. Betts has just recommended just some wordsmithing of the amendment. So she actually appears to be supportive of the amendment, but had some wordsmithing suggestions that were in the Word document. Is that how you read it, Colleen?
In the one that I just forwarded, the email?
Yes.
Yes. Yeah, I think that's right. It looked like just really wordsmithing the new provision related to the product registration fee, just clarifying that language.
Yep.
That's what it looked like to me.
Okay.
Yeah.
Great. Okay. Is there a discussion on the bill? There does not appear to be. Representative Morris, go ahead.
Thank you, Madam Chair. I hadn't intended to. I certainly understand the need for this legislation, or what we're getting at with this. I do have concerns about some of the constitutional issues raised, and you know, some of the I'll leave it at that. I think some of the constitutional issues certainly concern me. I would certainly support on this specific bill doing one of two things. Number one, carrying it over, or potentially two, turning it into a resolve to determine more about, to learn more about what these companies are actually doing to help people in these situations, and making sure it's more known to folks that are in need of insulin, what these companies are providing, and requiring that. But I have concerns about the language, the way the bill is written, particularly some of the constitutional questions raised. So that's really, you know, where I am with this specific bill.
Representative Tepler.
Thank you, Madam Chair. And I do just want to say that we received testimony from Ms. Koch, I believe, about the extreme limitations of the manufacturers' provided programs, and her concerns about how difficult it was to qualify for those programs.
Okay. Is there any further discussion on the bill? All right. Seeing none, and really appreciating all the work that Ms. Cohen put in at my request to help us get to a place where this was a manageable program that could really help people. I'm going to move on to pass as amended. Is there a second? Seconded by Representative Evans. And is there any further discussion on the bill? All right, seeing none, I'll have the clerk call the roll.
Representative Quint, Representative Connor,
No.
Representative Blyer,
No.
Representative Mars,
No.
Representative Matheson,
Yes.
Representative Evans,
Yes.
Representative Afford,
Yes.
Representative Melorano,
Yes.
Representative Brooks,
Yes.
Senator Stewart is absent, Representative Senator Brenner,
Yes.
Representative Tepler,
Yes.
and Senator Sanborn.
Yes. Okay.
Eight in favor of the motion, 3 in opposition, and 2 absent. And the opposition, is that ought not to pass, or?
Nope, it's ought to pass as amended, turning it into a resolve, and we will get the language for that to Colleen.
Okay, thank you.
Okay. Next, I have lost my list of bills, so hold on just a moment while it reloads so that I can find the LD number, because I don't remember numbers.
Well, we have 1117 and 675 left.
Perfect, thank you so much. So we're going to pick up 1117 next. And it is an act to prevent excessive prices for prescription drugs. There is a sponsor's amendment, and I think Colleen has worked the amendment into her analysis. So I'll have her pull up.
Sure. You want me to walk you through? Okay. We'll do that next. Did you say 1117 or 675? I'm sorry.
1117, we're going to do first.
Thank you. Sorry about that.
No problem.
So this is LD 1117. This is an act to prevent excessive prices for prescription drugs. As drafted, this bill prohibits excessive price increases for generic and off-patent prescription drugs sold in Maine. The bill provides that a price increase is considered excessive when the price increase adjusted for inflation using the Consumer Price Index exceeds 15% of the wholesale acquisition cost of the immediately preceding calendar year, or 40% of the wholesale acquisition cost of 3 years prior to the current year. And the price increase adjusted for inflation again exceeds $30 for a 30-day supply of the prescription of the generic or off-patent prescription drug, or for a course of treatment of the generic or off-patent drug that lasts less than 30 days. The bill does provide that it's not a violation for a distributor or a pharmacy to increase the price if the increase is directly attributable to additional costs for that generic or off-patent drug imposed on the distributor or pharmacy by the manufacturer. And it does make prescription drug manufacturers who violate the provisions of the bill subject to enforcement action by the Attorney General. Oh, sorry, I might have to redo it. It's not coming through here, so let me pull it up again. Sorry about that. Don't know why my PDF version didn't work. Here we go. So as Senator Sanborn mentioned, the sponsor did share a proposed amendment to the bill that was emailed yesterday. That was revised, I think, in part to address some of the concerns that were raised at both the public hearing and in written testimony. And so some of the things that the proposed amendment does are outlined here. One, it would transfer responsibility for notifying a manufacturer in the AG's office of an excessive price increase to MHDO rather than administrators of state programs and state agencies, and would require the reporting of certain information that would require them to report certain information. So it really focuses in on the MHDO and the AG's office working to identify those manufacturers that have been identified as having an excessive price increase for a particular drug. And I think this is my error, but the potential civil penalty is increased in the proposed amendment from $10,000 per day to $30,000 per day. And that was my mistake in reading the strike-throughs in the proposed amendment that the sponsor brought forward. So my understanding is the intent is to increase the civil penalty from $10,000 to $30,000 per day. And then lastly, the bill as drafted would require or direct that the AG's office assesses a penalty of $500,000 on any manufacturer that withdraws an identified drug from sale or distribution in the state for the purposes of avoiding the fine. And the language of the amendment would clarify that a court may issue an order to impose that penalty upon a petition by the Attorney General's office. So that's the suggested change there. I think in part, some of the changes were in response to some of the legal issues and constitutional issues that were raised by manufacturers and others in testimony that the committee received. And then you did also receive some written testimony from the Department of Health and Human Services about the potential impact on main care. And I think in part, as I understand it, the transferring the responsibility for identifying excessive price increases to MHDO may have been intended to address their concerns raised, because they have indicated that federal regulations really dictate under the main care program what amount is paid to pharmacies for the cost of prescription drugs. And then I did want to note that I believe that there are representatives of the Attorney General's office here if the committee has any specific questions for them. And I would also note that this legislation is based on a model law developed by the National Academy of State Health Policy. And some of this information was shared with you before, but the links to their model law, their policy brief that identifies some of the legal challenges and issues and how the model responded to those. And then they also have a tracker that looks at other states that are considering similar legislation. And I believe there are 5 other states that are looking at adopting this model. And representatives of NASHB are also here, I believe, at the work session if you have any specific questions for them.
Representative Blyer.
Thank you, Madam Chair. Colleen, just a correction. You stated that the daily fine was going to go up from 10,000 to 30,000, but it was written that it was going down from 10,000 to 3,000.
Yes.
Was that just an incorrect statement, or is
That was my mistake. The amendment that I shared yesterday would increase the amount of the, as I understand it, from $10,000 to $30,000, and I just misread the amendment when I was looking at the track changes version that I received. So that was my mistake.
Okay, is there any further discussion on the bill? Representative Morris.
Thank you, Madam Chair. If there are folks here from the Attorney General's office, I would certainly have questions for them.
Okay, great.
I'll pull them in.
I'm not sure who is here from the Attorney General's office.
Chris Taub from the Attorney General's office is here. I know he may have been called away to another work session, but here, I don't know if he's
here
physically here at the moment or not. I just pulled him in.
Okay.
There he is. Yes.
Good afternoon, folks.
Can you hear
I
us?
think our chair just power
I think
again.
he froze. Yeah.
Okay.
So why don't you go ahead, Representative Morris?
Yes, thank you for being here. My question is really deals with what happens on, I guess it's really these next two bills that we're going to be dealing with that deal with a lot of constitutional issues, and just sort of, you can touch on, as I understand it, there have been challenges to laws similar to this in other states. What are the chances that we would prevail, and what happens if we lose on constitutional grounds? If it's challenged and the state loses on constitutional grounds.
So yeah, those are all excellent questions. The two bills have some of the same issues, although one of the bills has a third issue as well. The two potential challenges that I think could be brought to 1117 are a Commerce Clause challenge and also potentially a takings challenge. And so one of the things that the Commerce Clause does is it restricts states from regulating things that are occurring outside of their borders. And so the problem or the challenge that comes with regulating pharmaceutical sales is that we don't have manufacturers selling drugs directly in Maine. As far as I know, they are generally located out of state, and they're selling drugs to distributors in another state. And then those distributors, maybe even through another intermediary, are eventually selling to the pharmacies that are in the state. And so I think one of the potential issues with this bill is that it could be argued that by putting limits on the prices that pharmaceutical manufacturers can charge, and I think that the bill is sort of is phrased in terms of the wholesale price, I think an argument would be made that we are essentially trying to regulate the transaction that's occurring wholly outside of Maine, the transaction that's occurring between the manufacturer and the distributor. And so challenges have been brought. In fact, there was a challenge, I think it was about 20 years ago in Maine to a pharmaceutical drug law. We survived parts of it. The case eventually went up to the U.S. Supreme Court. We did, though, in the district court in Maine, we did not prevail on the Commerce Clause challenge. The court there held that that one aspect of the statute that purported to regulate the prices of transactions that were occurring out of state violated the Commerce Clause. The most recent case is out of the Fourth Circuit, and that was a Maryland statute that I think in some respects is similar to the bill that's in front of you. That was challenged on Commerce Clause grounds. again, on the theory that Maryland was attempting to regulate transactions that were occurring outside of the borders. I think in that case, the district court originally found in favor of the statute, but the Fourth Circuit Court of Appeals reversed and found that the statute violated the Commerce Clause. Maryland filed a petition for certiorari with the US Supreme Court, and the Supreme Court denied cert. So that was the end of that case. In terms of ramifications, certainly for Commerce Clause challenges, when an entity prevails on a Commerce Clause challenge, they're generally entitled to recover their attorney's fees that they incurred as part of the challenge. It's really, and I know that you're going to ask me, well, what would the attorney's fees bill be in a case like this? And it's very hard to predict. I did look at the Maryland case, and when they lost, the manufacturers who were suing submitted a bill for, I think, I want to get you the number here. I don't want to give you bad information. $1.7 million in attorney's fees and costs. Maryland eventually settled. I don't know what they settled for, but presumably it was something less than the 1.7 million that the manufacturers had demanded, but that information is not public, so I'm not privy to it. In the past, when we've lost cases on Commerce Clause or other grounds, we've seen bills on the order of $600,000-$700,000, but that was a number of years ago, so I'm assuming that sort of legal fees have gone up in the interim. In terms of your question, Representative, of sort of what the chances are that we would prevail, I wish I could give you a better answer, and I don't want to try to sound evasive, but these are just really hard things to predict because these laws are all sort of unique. This law is different than the Maryland law, so just because the Fourth Circuit struck down the Maryland law, that doesn't mean that our law would fail. I can say that I think that the challenge would be substantial. I think, I don't think we have better than 50% chance of winning. I think at best we have a 50-50 chance, but it would definitely be a substantial challenge. And I don't know if I've answered all your questions or if I've adequately answered them, but if I didn't, I can try to clarify some more.
No, I think you answered my questions. I appreciate it.
Representative Bleier.
Thank you, Madam Chair. Thank you, Mr. Toll, for being here. So from what I'm hearing you correctly, I think so if there's already been a court case that's been, gone through the process and they've lost, I would think that our chances are even less because it's already been proven that this is a losing proposition. And so putting something forward that would potentially put the state of Maine not only, liable for attorney's fees for the pharmaceutical companies, but also the time spent for yourself, bringing this forward in a court of law with a best possible chance of winning is 50% is not very good odds, in my opinion.
Well, so Representative, I guess just one or two things I would say to that is, first of all, I mean, you're absolutely right in the sense that the Fourth Circuit case is going to be a difficult barrier because that is a court of appeals. It's not binding in Maine. Each sort of, they're different circuit courts of appeals. We're governed by the First Circuit. Maryland's governed by the Fourth Circuit. So just because the Fourth Circuit held against that statute, that wouldn't be binding on courts in this state. But on the other hand, courts are going to give a lot of deference to a considered opinion from a court of appeals. But court of appeals get things wrong, and that's why we have the Supreme Court to correct them when they do make bad decisions. So it's possible that, even though the Fourth Circuit ruled one way, that the First Circuit might rule a different way. And I think there are some distinctions that we could make between this bill and the Maryland statute. How meaningful those distinctions are going to be at the end of the day, I'm not so sure. I think really if you just step back to sort of 30,000 feet, I think, speaking at the most general level, both the Maryland law and this bill, I think do sort of either intentionally or unintentionally, but directly sort of impact what these transactions are being done out of state. So it's going to be a challenge, and I guess that's sort of the best I can say.
Okay. Are there additional questions for Mr. Taub? All right, I am gonna bring in Drew Gattine from Nashpee to try and say more about how Nashpee tried to distinguish the Maryland case, because I think it'll be helpful to the committee. I don't know what the answer is, so I think it's always helpful when I don't know the answer.
I've made it through the wormhole.
Welcome, Mr. Gattine. It's nice to see you, one of my constituents. So can you speak to the question of what was done in this model to try and distinguish the Maryland models, specifically on the Commerce Clause piece? Because I know there's also a patent law piece, but this is separate from that.
Yeah, thank you, Madam Chair. And again, pleasure to be here in front of this committee virtually, and the opportunity to put on a jacket and tie on the first 90-degree day in Maine. Is certainly something I'll remember about today. So again, I listened to Attorney Taub's testimony. It has been many, many years since I've practiced law, so I'm certainly not here to disagree with his legal thoughts or analysis. I do want to say and just emphasize a couple points that may have already been made, but I just want to emphasize them. One is with respect to this model bill, and Nashpee has created several model bills that are making their way through various state legislatures this year. With this bill specifically, we were obviously aware of the Frosch case. Our work on this bill started with the Maryland bill, started with the Frosch case. We commissioned a legal analysis, which is available on our website for folks that want to read it. So we're very transparent about where we came down on Frosch. Again, just want to say that, if you read the Frosch case, an important part, it seems to me, or it seemed to our legal team with the court's analysis, is that what was trying to be regulated there was any drug that could have been covered or any drug that could have been sold within the state of Maryland. So, conceptually, the Maryland law that Frosch was looking at could even touch transactions that didn't result in a sale within the state. The primary thing that we did with this bill and with others, that touched the Commerce Clause issue, was to draft the bill to make sure that the actual transactions were based on sales within the state. Also have language in the bills to draw a tighter nexus between the manufacturers and the state by requiring that they retain a registered agent and office within the state. So, when you look at the Frosch case, again, I'm not here to contradict Chris. It is from another circuit. It was a 2-to-1 decision, with a very strong dissent for what that's worth. Certainly there are people, including our legal team, who are not convinced that it was rightly decided. So again, as Chris said, you never know what a court will decide. Certainly, I think we've got some pretty litigious players in this space, states have to consider that very carefully. But on the other hand, I think there's a point of view that states will never make progress, on this really important issue around drug pricing, because if they are back off when threatened with litigation, because that threat will frankly always be out there by manufacturers. So that's really all I wanted to add, Senator. Thank you.
Thank you, Mr. Gattine. Representative Morris.
Yes, thank you, Madam Chair. And I wonder if we might bring in Ashley Van Meter to discuss this as well, since they raised a lot of the issues at the public hearing related to the constitutional issues and with the amendment and so forth.
We can in just a minute. Let me make sure that we've kind of asked the questions we want to ask of Mr. Gattine first, and then we can leave these guys on the panel as well in order to come back to them if additional questions are raised. But let's just take folks one at a time, at least initially. Representative
Well, I would
Black.
have a question.
Oh,
Whoop,
Representative
sorry.
Morris, go ahead.
No, you can let Representative Blyer go. I'll ask if Representative Blyer doesn't have the question I have. So.
Okay, great. Representative Blyer, go ahead.
Thank you, Madam Chair. Thank you, Mr. Gattine, for being here. My question to you, Mr. Gattine, is why would you want to create legislation that would put the state of Maine into a potential legal battle that would cost the Maine taxpayer resources in order to fight a law that has been lost in another state?
Well, I mean, again, Representative, NASHB did not really is testifying as a neutral party, neither for nor against this bill. We're here to support the sponsor and to give technical support to the committee. But I think the answer to your question is that we hear all around the country, in all the states that we work in, that this problem of unsupported, dramatic increases in prescription drug prices is incredibly important. And what NASHB does is we convene policymakers from around the country, red states, blue states, purple states, and have this conversation. And we hear time and time again that this is a really important issue. And we create model legislation that gives states an option to look at that. And again, as I said a couple minutes ago in response to a question, they are, the manufacturer community is very litigious, and if states allow themselves to back off every time there's a threat of litigation, then states will put themselves in a position of never being able to move this ball down the field. And we did. This is not exactly the same bill. This is not the same bill as Maryland. It was changed, frankly, in order to differentiate it from the Maryland bill, with full knowledge what the Fourth Circuit said. So, that's my response.
But then just to follow up, Madam Chair, if I may. So we just heard from Chris that our chances of winning are at best 50%. So I look at that saying, you know what, the state is going to be holding the bag on a financial responsibility on an idea that you want to push forward, that the chances of us winning are less than 50%, in my opinion. So why spend Maine taxpayer resources on something that the chances of winning are so slim? What's the objective here?
Well, I think the objective here, frankly, is to prevent price increases. I mean that is the objection. The objection is not to pick a fight. The objection is not the litigation. The objective is the result. And again, I will defer to the sponsors and also to some of the testimony that you heard in support of the bill on the day of the public hearing. And I think it's pretty obvious that these large increases in prescription drug prices, whether they're generics or brand name drugs, and again, this bill is specific to generics, really are a very important issue to people. They have a real impact on people's pocketbooks, on people's ability to pay for other things that they need. And if the result of this is a fight with the pharmaceutical industry, then I think it's up to the legislature to decide whether that fight is worth having.
Representative Tupler.
Thank you, Madam Chair, and thank you for being here, Mr. Gattine. It's good to see you. I am wondering if NASHB has any notion of whether the Biden administration is considering making any movement on controlling drug prices. I mean, one of the reasons we've come to state attempts to control drug prices is because the federal government hasn't yet. I'm just wondering if there is anything out there that may happen soon.
Well, it's the happen soon part, right, Madam Chair? That's the problem. I mean, the whole basis of NASHB's work is that we think that We think that the states are a vibrant place, an important source of innovative policy. We know that the federal government historically, certainly lately, moves very, very slowly. There are a number of bills, making its way through Congress, that if passed would have a good impact on prescription drug pricing. Whether or not those are going to be part of a proposal from the actual Biden administration isn't clear. The thinking is that the president's budget will come out on Friday, and based on what NASHB's hearing, we don't expect to see significant RX provisions in that budget.
And just as a follow-up, so you're not hearing about any executive action either?
Well, I'm probably not the best person to answer that question. Again, we are I'm very focused on the state health policy. Certainly as part of that, our RX team watches very closely what's happening in Washington, D.C. and HR 3 is out there in the House, and other bills are making their way through.
Thank you.
Representative Connor.
Thank you, Madam Chair. Thank you, Mr. Gutin. Just a clarifying question. You had stated that you are neither for nor against this bill, but the testimony that was submitted is clearly in support of. Can you just clarify which it is? Is it in support or is it neither?
Yeah, I believe that we testified. I think Jennifer Reck from NASHB testified on this bill, neither for nor against. Again, we are a nonpartisan organization. We work with Republican sponsors in some states and Democratic sponsors in some states. And our position is that we support our sponsors and we support legislators really with technical support. Now, obviously, we drafted these bills because people told us that they thought that these bills were something that legislators might be interested in. We also continue to support if bills that we have drafted become law in states, we continue to support those bills through implementation and convene groups. Just as we were having this work session today, all of the states that have enacted transparency legislation were convened by NASHB as part of our transparency work group. So we start at the beginning and we stick through. We stick with it all the way through.
Okay, thank you. Like I said, I just wanted clarification on that. Thank you.
Thank you.
That's all I had, Madam Chair.
Thank you. Representative Morris.
Thank you, Madam Chair. To your knowledge, Mr. Gutin, have any states passed the model legislation, either this one or 675, to your knowledge?
No. I mean, the short answer is no. Representative, NASHB released 3 model bills at the end of the summer in 2020. I think we had those bills introduced in 9 states. So this was really the first session that these bills were being worked. The price gouging bill that's in front of you right now was introduced. It's been introduced in Minnesota, Hawaii, Delaware, in addition to being introduced in Maine.
Are they still pending, or are they?
They are.
Okay. Are there any further questions from Mr. Gutin? Mr. Gutin, has NASHB done any analysis on how much this, like, if you go backwards and look at some of the price increases that have happened in the past with regard to generics, like how much bang for the buck is there here, right? How many generics would have been caught up? And of course, the rules weren't in place, so the generics manufacturers, wouldn't have avoided price increases as a result. But any analysis on what amount of money we're going to save Mainers here?
I don't have that information, Senator. Again, the goal here again is to stop the price increases. It isn't to collect the fines. you know, and obviously some of the impetus of this bill was, you know, some of the large increases in a generic drug prices that you know, have occurred over the time and been well publicized. We don't have access to Maine specific data to do that type of Maine specific analysis. You know, certainly would be willing to work with the sponsor of the committee in terms of pulling that together.
So I, like a lot of people, have gotten a lot of emails in the last 4 hours or so opposing this bill. And I assume all the other members of the committee are receiving them as well. And the argument is this is 3% of our drug costs. The whole generics world is 3% of our drug costs. So I'm trying to wrap my head around where are we just going to catch the one guy, Shakreeli or whatever his name was, who raised EpiPen prices? I think that's the famous example. But is that it, or are there a lot of examples of generics manufacturers raising above the thresholds?
Yeah, I think we listed a number of examples in our testimony, Senator. You know, I don't know where that 3% number comes from. I'm not getting those emails, you know, as you can imagine. Not at this point in my life, but you know, I mean, we still hear that this is a problem. You know, when we convene our state working groups, which includes legislators and executive branch folks, they still hear that this is a problem. I wish I had some more specific information on that for you.
Okay. Anybody else have any questions for Mr. Gattin? All right. So Representative Morris had asked for Ms. Van Meter to join us, and I'm happy to do that, but he's not with us at the moment. Are there others who have questions for Ms. Van Meter? Because I don't want to bring her in and then we all sit here and stare at each other. I'm not seeing any hands go up, but I don't want to cut off. Oh, there's Representative Morris. Representative Morris, I'm sorry. We were just about to turn to Ms. Van Meter, and I didn't want to call on her without you here because no one else had questions for her. So.
Yep. Yes.
Okay. So you're back. So
yes,
I will ask the real Ashley Van Meter to raise her hand because there are two of them. So if she could raise her hand, and then we'll bring her in.
I'm having issues with my computer again, so I'll just do voice. I apologize for that. That's why there's two Ashley Van Meters.
No problem. We can hear you okay right now, but probably would not be able to hear you if you turned your camera on. Right. So I think Representative Morris had a question for you.
Okay. Yes, thank you, Madam Chair. Thank you, Ms. Van Meter. Yeah, my question just deals with a lot of what I asked the Attorney General and some of the issues raised by NASHP around the constitutional issues. If you could just touch on those as far as you know, as far as how they are with the bill as amended.
Sure. So unfortunately, the bill as amended still bears a striking resemblance to the Maryland bill that the Association for Accessible Medicines did sue on in the state of Maryland. And also in the other states that NASHP had this bill introduced, Maine was one, obviously, Hawaii, also in Minnesota and also in Delaware. The bill is dead in Hawaii. It's also dead in Minnesota. And the sponsor in Delaware has told us that after their AG, assistant AGs and other attorneys looked at it, they felt as though the bill was strikingly similar to Maryland and it was not worth the risk of litigation, and did not feel that it would ultimately bring down drug costs because generic manufacturers are not the ones that are driving costs. Generic drug manufacturers saved Maine $1.8 billion last year alone. A lot of the drugs that have been listed in NASHP's testimony and that have been talked about today are off-patented drugs, not generic drugs. For example, I believe that Chairwoman referenced Mr. Scarelli. He was actually not EpiPen. he produced Daraprim, an off-patent drug that then he skyrocketed, obviously, the prices on. And so we had our outside counsel that actually argued the Frosch case and won, do an analysis of the bill and the changes that were made by NASHP prior to introduction and through these amendments were not actually at issue in why the case was found the way it was, why it was not determined to be appropriate because it violated the Dormant Commerce Clause. Because even if you have a registered sales agent in the state, the practice of the way generic drugs are sold to the state, we do not directly sell to the state of Maine. We sell to wholesalers. We do not bring it into the state of Maine, so there still would not be a sufficient nexus with the state of Maine. It would still be deemed to be trying to affect prices in situations outside of the state. And I too am an attorney. I don't practice anymore, and I don't want to argue with the sort of 50-50 split. I would say that it's probably less than that. However, it's something that I know that some of the questions were asked, and yes, it's true. We did get attorney's fees paid to us. We did spend over $1.6 million in attorney's fees, and we did settle with the state of Maryland, and they had to pay us a substantial amount of that back to us since it was deemed unconstitutional.
There are additional questions for Ms. Van Meter. Ms. Van Meter, I'm going to ask you the same question that I asked Mr. Gattin a minute ago. He seems to, oh, he went up to the corner. I was like, where did he go? My question that I asked him a moment ago, and I'm asking you because I think it would be in the interest of the Association for Affordable Medicines to have an answer to this question. So I'm going to give you the opportunity to have the answer, which is, you know, how many generics are likely to hit this trigger, you know, or would have hit this trigger in the past, and to what sort of dollar amount savings or effect on Maine consumers, you know, what order of magnitude are we talking about? And I guess what I'm trying to figure out here is the sort of risk benefit analysis of this, you know, which is, I think, the substance of the emails campaign that is going out. So that's why I give you the opportunity to make that argument.
Okay, so I think the number one problem is we were asked, like we do with the Affordability Board bill, like we did with the Transparency bill, to work on the underlying triggers. So the triggers in this bill do not have anything like a WAC floor. So when they say something like a 30% increase, you could pull in a lot of really cheap drugs if they took a 30% increase. Obviously, the majority of generic drugs decrease in price. That's why we're able to say the 3%. And it's from all of the data that we've got from what I alluded to earlier today in California, from Medicaid numbers, from also IQVIA and other sources. But because the law wasn't passed, I don't know how many would get tripped up in it. We thought it would be disingenuous to try to fix a bill with the triggers that we will still ultimately sue over.
Okay, that wasn't my...
Simply because, okay,
yeah,
I don't have an answer to your question about how many drugs would hit the triggers.
How many drugs sort of would have hit the triggers in past years?
I do not have that information.
Okay.
The individual manufacturers have their pricing information. We're not allowed to have their pricing information due to antitrust laws.
Yep. Okay. So, and then you note there's no WAC floor, but there is a $30 floor. The increase has to be at least $30 for a 30-day supply, or else the bill can't be triggered. So an 11 cents medication that quadruples in price can't ever hit this trigger.
Right.
Would you agree?
But if you look at some of the drugs, even a drug that is $30 for a 30-day supply, that is still a pretty cheap drug compared to some of the drugs that are actually driving costs in the state of Maine. They're not a $30 drug, and that's not what the consumer pays anyway.
Right, but we're talking about a $30 drug that is now suddenly $60, or else it can't hit the trigger in the bill because it has to be a $30 increase.
Well, that would be 100% increase.
Correct, but the minimum increase to hit the trigger is $30. So on a $30 drug, the only way you could hit the trigger is with 100% increase.
I believe it's 30. I thought it was 30%.
It's 15% and it has to be more than $30.
Right. So you're saying that I guess I'm not understanding what your question is. That, yeah, if a drug hits the trigger, obviously they'd get pulled into the statute, but I don't know how many drugs would do that. We just did not feel, we went back and forth and we talked to folks, and including the sponsor, to see if there were ways to make this a better situation where you get honest answers about what drugs are hitting them because they're taking inappropriate price increases. We don't think the way that the bill defines it, there would necessarily be an inappropriate price increase because of the way generic manufacturers and their supply chain works. However, we didn't want to argue that we were fine with the bill and everything was great because we got the correct triggers when we would still sue because it's so blatantly unconstitutional.
Okay, Representative Evans.
Oh, yeah, thank you, Madam Chair. Ms. Van Meter, has I forgot what I was going to say. The trigger. Has the trigger remained the same or does it change? When was the last change in the trigger?
I don't understand your question, Representative Evans. Do you mean in the bill draft? I need to understand what you're asking before Ms. Van Meter answers that.
Well, some of the drugs, they're not reviewed. The problem is not apparent until you reach a certain level, and that triggers the evaluation or furtherance of an evaluation. So my question is, how do you determine the trigger? Because if the trigger is low and you have, and we talked about this earlier, you're capturing only the lower cost drugs, which may not be the most expensive, whereas it could be the top 25 drugs that are actually the problem. So what determines when you move the trigger? And when was the last time it was moved?
That's the piece I don't understand. There is no trigger. We're looking at a bill that isn't law yet, Representative Evans. So I don't understand what you're asking about who moved what trigger. We're considering a bill that is not currently law.
I understand that, but she used the term trigger again, and that's why it caught my attention.
Okay, we're talking about the draft of the bill, and I don't think the language of the draft has changed around the trigger. So I don't think there's like a question about when was the last time it moved, because there isn't one in law and there's a proposed one and it hasn't changed.
That was my point, because she raised the issue of the trigger again.
Sir, I was referring to the Affordability Board bill that was passed and also the Drug Transparency bill. There are different triggers in law for that. That we talked about earlier when you were all doing a work session on LD 686. That has a different set of triggers for when folks had to report. And so I was just making an analogy to the triggers. We negotiated for triggers for that one, but we didn't go into a negotiation for trying to fix these triggers in this bill because we felt like we would still sue on the bill and didn't want to lead folks down the path of thinking we were fine with it and then suing.
But that was
I don't know if that helps answer.
Yes, it does, because that was a reference that you made.
Okay.
Yeah.
I think that actually Ms. Harrington might be able to help us work through some of this question about triggers and what the right trigger is or how the triggers compare and so forth. So I'm gonna suggest we turn to her to get untangled on that point, Representative Evans, because I think we're going down a weird rabbit hole there. Representative not Representative Gatine anymore. Mr. Gatine had his hand up. I think you had an answer to an earlier question that I had asked.
Yeah, thank you, Senator. Again, I don't have broad statistics, around the number of bills, but again, number of examples. Fluoxetine, which is a generic version of Prozac, jumped from $9 to $69 in January 2019. 667% increase. Guanfacine, which is a generic treatment for high blood pressure and ADHD, went from $29 to $87, 204% increase. That was also in 2019. The generic version of a chemotherapy drug, Vidaza, jumped from 105 to 210 in 2019. Again, basically 100% increase. So these examples are out there. Also, I know this is not a place for debate among invited guests. I just want to say that I checked this morning with Minnesota. The price gouging bill is still alive in Minnesota. There's a House version with a Democratic sponsor, and there is a Senate version with a Republican sponsor. My understanding of Hawaii from my conversations with the sponsor is that bill that the bill is still alive in Hawaii, and will not be taken up this session, but is there for next session. I think they wrapped up their session a while ago, and certainly I've been in contact back and forth with the Delaware sponsor and haven't heard the same information that Ms. Van Meter presented to you. So just wanted to clarify that a little bit.
Okay. Ms. Van Meter, go ahead.
Yeah, and I understand. I'm not arguing that there are not examples of bad actors in the marketplace. What I am saying is, on the whole, generics save consumers money. It's study after study from AARP has shown our prices on trend are declining. Branded prices are driving prescription drug costs, not generics. But this bill does nothing towards that. There are drugs right now that are driving costs that are not brand, that are off patent. That is different than generics. Some of the examples were given, they are off patented drugs, not generic drugs. And so you got to be careful of how you classify them when you're giving examples. Also, some of the discussion that was going back and forth earlier about what was done in other states, there's a reason that a lot of other states are not doing this with generic drugs. It is because we are providing savings, and they did see that the law was found unconstitutional. And I mean, even with Maine's own data that has been collected over the course of the last few years with the top 25 list, and with the data collected through the bill we were talking about earlier today, generics are not the problem. Yeah, there are examples of bad actors, but they're getting caught with your legislation or your law that is in place. And also, after Mr. Scarelli pulled the stunt that he did, the federal government came in and FDA watches it, and they have a list of these sorts of drugs, and the federal government has acted in this space. And so, I mean, it just seems like a high risk of losing a very expensive lawsuit for a very few amount of examples. So I just find it hard to understand why, and also pushing so hard if you're neither for nor against. I just don't understand that.
Okay. Let's try and untangle the generic versus off patent piece that you just talked about. This bill draws no distinction between the two. I understand that you represent manufacturers of generics and not off patent drugs, but as far as this bill is concerned, and as far as Maine consumers are concerned, is there a meaningful difference between them that we need to elucidate in some way here?
Well, yeah, with off patents, it's essentially a drug that is no longer patented, no longer enjoys monopoly, but there's no competition because no generic manufacturer has been, quote, incentivized to make it for a number of reasons. And so that's when you do see when there is a bad actor that finds a product like that, and they do stuff like what happened with Mr. Scarelli, and you see them jacking up the price to an unbelievable amount of money in a short amount of time. And then he did things to hold out so that generics could not enter and compete. So there's often a difference with off-patent versus generics. Generics, the incentive behind generics is get in there first and start the competition with the brand, and then more generics come to market to enjoy a free market, to compete with one another, to be the lowest cost so that you're picked.
Mr. Gattin, I keep calling you representative. Go ahead, Mr. Gattin.
I'll be really quick. I just want to make sure it's very clear, Senator. I think you made the point, is that when you read the proposed bill in front of you, it does cover both generic and off patent. So I mean, I just want to make it clear, if there's an argument being made that it doesn't cover off patent, it does cover off patent in addition to generics.
Okay. Okay. So at this point, I don't see any other hands up. I think what would be helpful is I'm going to push the folks who we've spoken with so far at length back through the wormhole. I'm going to bring in Ms. Harrington to provide us with a little bit more information, like from a data perspective on answering some of the questions that I just asked. So I'm going to bring her in while others are pushing people out. Okay. Oops. Okay. We can. I think you have some information from the report about maybe how many generics might have hit, at least different triggers, but triggers.
So in our first annual report, based on the triggers that are currently in the transparency law, manufacturers reported to MHDO that there were 192 drugs that hit one of the triggers. And of that, 56 were for generic drug price increases, 123 were for newly introduced drugs, and 13 fell into the category for brand name. So I just wanted to give you that context. The thresholds in the bill that you're looking at are lower than the thresholds that are currently in the law that MHDO is administering. But that just gives you some context. And remember, there are something like 30,000 NDCs that are out there. So just some context.
Is there any way to put any kind of numerical or like a money estimate on what the price increases on those 56 generic drugs times the amount of utilization in Maine equals, so that, you know, the triggered drugs or the reported drugs, those 56 generics equal an additional $30 million last year in costs to Mainers, or an additional $4,000 in costs to Mainers, because those are like two different orders of magnitude.
You know, I think we could look at that. It's not information that I have readily available right at this moment. But I do think we could look at that. And the other thing I just wanted to say is, in our report, we did, you know, summarize that in most cases, not in all, but in most, the generic equivalent is less costly than the brand when evaluated against the wholesale acquisition cost. And, you know, we had identified that although the generic increases may, you know, as was mentioned earlier, may increase at a higher percentage rate than the brand, they're still less costly than the brand equivalent. So you know, the sample that we looked at and the analysis that we did and what we put in that annual report underscores those points.
Ms. Harrington, though, if they're the same drug, the brand equivalent is now an off-patent medicine. Isn't that right?
I don't think it's off. I think there's a different definition for that. Like there aren't generic equivalents that are being made. If it's, I'm not, I don't want to answer that because I don't know that I have the expertise. I know Jim is still on if you want to pull him in.
Okay. I think that would be helpful. I mean, I think we should know what we're doing here, which is why we're spending a lot of time on this committee. I know we don't often have long work sessions like this, but we really need this information.
Yes. And one other thing I just want to say while you're pulling Jim in, you know, we can certainly, if the committee is interested in us analyzing certain aspects of this, like you just asked me, you know, could we look at, you know, the impact in terms of the cost to Mainers, all of that. We can certainly do that. It just is going to take us time.
Mm-hmm. Welcome back, Mr. Jones. So my question, as we're trying to sort out this, you know, the question of the brand versus the generic versus off patent. My understanding is that this bill would apply to any drug that the patent has expired. So if there's a generic, by definition, the brand drug is now an off-patent drug. Is that right?
That's generally correct. When the first generic drug manufacturer comes to market, it's oftentimes an authorized generic, and that happens toward the end of a patent life cycle. So it's possible that a branded drug may still be under patent in those circumstances, but what we're talking about is generally in the more commoditized generic space, where the brand drug would be off patent.
So the brand drug still exists and you guys are still doing an analysis on its cost, but really it's just sort of an off patent drug competing against the generics of the same thing. Is that right?
That's right. And there's certainly dynamics that go into pricing after a drug comes off patent and the generic space opens up. But that's, you know, really getting in the weeds, and we could do more analysis on that if there are specific questions you're interested in.
Okay. And I guess this is a slightly different question for Ms. Harrington or Mr. Jones. The triggers in this bill are different than the triggers in the reporting bill. And I know that we did work really hard on the generics triggers in the transparency bill. Can you, either of you, speak to the generics trigger or the trigger in this draft of 1117 and whether it should mirror our reporting triggers?
I can definitely speak to the difference if you'd like. Yeah. This bill looks at price increases of 15% in the calendar year or 40% over 3 previous calendar years in a cumulative way, where the increase itself is $30. And so that would be for the package WAC. The difference between that and what was passed with 2019-1162 is that the triggers there for generic drugs are a 20% increase, and the unit price. So if we were talking about a bottle of tablets, for example, each tablet would have to have a unit price of $10 or more prior to the increase. So that does have a difference in floor there.
So that's the WAC floor that Ms. Van Meter discussed?
That's correct. In the current bill, there's no WAC floor. The floor pertains to the amount of increase on a package level.
Okay. And is there any cumulative trigger in the MHDO or the 1162 provision?
There is not.
Okay. Okay. Are there additional questions for Ms. Harrington or Mr. Jones? All right. Thank you for joining us. I'm going to send you folks back. Okay. So committee, my sense of this is that there's some further discussion that we need to have, certainly as a caucus. We learned a lot this afternoon about this bill. but I don't want to break and do it right now, have that discussion right now, because we've got another bill that has some really similar discussion that we're going to have and is different. So what my thinking is that I'm going to table this bill, and then we would work on 675 and then potentially table 675 and then have time to digest a bit and probably return to both of them tomorrow, because I'm looking at the clock and thinking it's probably going to take us an hour to get through the next bill as well. I'm letting folks know that that's the plan rather than making a tabling motion, which is non-debatable, so that if there's anyone who would like to raise their hand now and discuss the plan or discuss the bill, you are welcome to do so. All right, seeing no hands go up, I move to table 1117. Is there a second? Seconded by Representative Tepler. And we will vote with our electronic hands for the tabling motion. All those in favor? Or Representative Melrano, Representative Morris, Representative Evans, do you guys not have access to your hands? You got it. Representative Evans.
Nope, I was just on autopilot. My apologies.
It's okay. I just changed the method on you. We use this one in judiciary. It seems to work better. It's easier to see for the clerk, I think. Okay, so now it's unanimous to table, so we can take our hands down, and thank you, committee, for the forbearance there, changing the rules at the end of the game here. Okay, so the next bill, and I think it's, Colleen, I haven't skipped anything, right? It's the last bill today is 675.
It is the last one, although we wanted to discuss those two carryover potentially, either today or tomorrow. Yeah.
Okay, great. I'll open a work session on LD 675, and I'm going to have Colleen do her analysis, which also addresses the sponsor's amendments kind of embedded in the analysis. So you can go ahead.
So we're working on LD 675 now. This is a bill also based on a model from NASHB, an act to protect Maine consumers from unsupported price increases on prescription medicines by creating an independent review process. The bill as drafted applies to all drugs, and it makes prescription drug manufacturers subject to fines for the sale of prescription drugs in Maine identified as having an unsupported price increase. As drafted, the determination of what constitutes an unsupported price increase is based on whether there was no or inadequate new clinical evidence to support the price increase, as demonstrated by analyses of prescription drugs that are prepared annually by the Institute for Clinical and Economic Review or its successor organization, as the bill is drafted. The bill would assess fines on manufacturers that have at least $250,000 in total annual sales within the state in the calendar year for which the fine is assessed. The amount of the fine is 80% of the difference in revenue between the generated sales within the state of the identified prescription drugs and the revenue that would have been generated if the prescription drug manufacturer had maintained the wholesale acquisition cost from the previous calendar year adjusted for inflation. So it's the difference between the price of the drug reflecting the increase and the price of the drug without the price increase. The bill does set up what's called the Unsupported Prescription Drug Increases Fund, to which any fines will be deposited, and as drafted, the fund directs the fund to be used by the superintendent to offset costs to consumers or to support the administrative costs to collect the fines. As Senator Sanborn mentioned, the sponsor shared an amendment yesterday, which makes some changes to the bill, I think in part to address some of the concerns raised at the public hearing. One of the changes relates to the definition of an unsupported price increase. It does remove the requirement that analyses be provided by the Institute for Clinical and Economic Review and replaces it with language requiring that an unsupported price increase be demonstrated by prescription drug data collected by MHDO. And I think that is intended to address some of the concerns raised about delegating authority to a non-governmental entity without due process. It would require further that the Maine Prescription Drug Affordability Board be tasked with identifying a list of no more than 12 identified drugs with an unsupported price increase based on that information and data provided by MHDO, and establishes criteria for identifying those drugs on the list. It also would permit the use of research from an independent research institute, as long as the methodology used does not discriminate against persons with disabilities. And again, that is intended, I think, to address a concern raised about ICER's use of quality adjusted life years as part of its current methodology. The amendment also would transfer responsibility for collecting fines from the state tax assessor to the state treasurer, and would provide that the Prescription Drug Affordability Board is responsible for determining the fine amount and making the manufacturer subject to the fine. I think this was intended in part to address some concerns raised by the state tax assessor about their lack of expertise in the subject matter. The bill, as amended, also would provide a right of appeal for a manufacturer to appeal the imposition or amount of a fine. So there's some language intended there, although there may be some further technical changes needed. And then with regard to the unsupported prescription drug increases fund, the reporting requirements related to that are transferred from the Bureau of Insurance to the Attorney General's office through 2026. And in 2027 and thereafter, the proposed amendment would transfer that responsibility to the Office of Affordable Health Care, which we discussed earlier as part of LD 120. The language also would allow the funds amounts in the fund to be used to support the administrative costs of MHDO, the treasurer, the AG's office, and the Office of Affordable Health Care to the extent that there are any. And then with regard to the assessment of the penalty, it makes some changes to that language, clarifying that the court may issue an order to impose a civil penalty on manufacturers that withdraw drugs from sale in the state to avoid the fine upon petition of the AG's office, and clarify some of the language in the original bill on that point. As with the previous bill, I think we do still have representatives of both the AG's office and NASHB who can speak to some of the legal issues that were raised. And according to the information that's on NASHB's website, I believe there are 5 states total, including Maine, that are considering similar legislation to LD 675. I'll stop there.
Okay. All right. Questions with regard to this bill? We've got another Darlene in the meeting. Who is that? Another clerk? Who is that?
Sorry, I'm not Darlene. This is Greg Olson from the Office of the State Treasurer, here to answer any questions as to our role for this bill.
Aha, wonderful. Okay. Thank you. That was confusing. Can somebody change his name for me? Thank you. I was very baffled by that. I apologize. Caught me off guard there for a minute when we stopped screen sharing. Okay, I have questions first, I think, for the Attorney General's office on this one. So I'm gonna bring in Mr. Taub. Good afternoon again. So can you speak to this bill and, give us the rundown?
Yeah, I apologize, Madam Chair, but I was distracted and so I lost track of what the committee is talking about. Are we on 675?
We are.
Okay. So this bill poses the same Commerce Clause issue that the other bill does, because of the fact that it does seem to attempt to regulate prices that are being charged by manufacturers outside of the state. And that's sort of highlighted by the fact that the way that the penalty is calculated is based on the wholesale price. So I think it's going to raise the same issue that the state is essentially trying to sort of reach beyond its borders and regulate sales of drugs that are going on between manufacturers and distributors. And the other additional issue that this one raises, because the other one only applied to generic drugs, but my understanding is this one is going to also apply to drugs that are still under a patent. And so there's likely going to be a challenge that the state is preempted from regulating the prices of patented drugs under the theory that sort of the purpose of patent laws, it's sort of a balance that Congress has struck to encourage innovation by then ensuring that the holders of the patents are able to achieve an appropriate financial return on their investment. And so there would be an argument that if a state tries to sort of tinker with the amount of return that the holder of the patent gets, it would frustrate Congress's purpose under federal patent law. And that is an argument that got made to the DC circuit back in 2007. It was actually the federal circuit. The District of Columbia passed a law that prohibited patented drugs from being sold at excessive prices. And the Court of Appeals held that was going to be preempted by federal patent law. So as I said before, just because one Court of Appeals has held in a certain way, that's not binding in our circuit, in the First Circuit. But it is a decision that is really directly on point. And that, if the First Circuit were to sort of defer to that decision or were to, give weight to that decision, it would definitely be problematic for us. There's also, I think there were a couple other sort of issues that we saw with this one that I think are fixable. And I don't know if at this point it's worth me getting in sort of the nitty gritty, but we did sort of see some things in the statute that were a little bit inconsistent or maybe internally conflicted with other provisions. And I'm happy to address that, but I'm not sure if the committee at this point is interested in getting into that level of detail. So I think just to sort of give you the big picture view, this law would definitely be subject to a Commerce Clause challenge and a patent preemption challenge. As I said before, I really can't predict what the success would be. Again, I think at best we would have a 50% chance of prevailing. And let me pause there and see if I've answered questions and if anyone has any additional questions.
So I guess my question is, I realize if there are like typos or cross references that are wrong, we probably don't need to do those on mic, but I do think we need to know what the problems are.
Yeah, so the first thing is that the treasurer is supposed to submit. So the way I understand this would work is that the main health data organization, or maybe it's the board, sends a report to the treasurer on what drugs have unsupported price increases. And then the treasurer is supposed to submit the proposed fines to the Kennebec County Superior Court for approval. That's just something we've never seen before. There's no, as far as I'm aware, there's no recognized process to sort of submit a proposed fine to the Superior Court. I don't know if the Superior Court would think it has jurisdiction to sort of do anything with that, or what the process would look like. Is there supposed to be like a hearing or what? So that just struck us as something that we've never seen before. And we suspect it would just raise a lot of questions about like how that process is supposed to work and what is the court supposed to do when it gets this thing being submitted to it for review. It also says that the manufacturers can appeal the fine to a court having jurisdiction over such matters, but it's not clear to us sort of what court that would be. I mean, there really is no court at this point that has jurisdiction because this would be a brand new law. So it might make more sense to somehow incorporate Rule 80C, which sort of sets forth a process under the APA for reviewing government actions. That would sort of be more definite and people know what an ADC process looks like and how it works, and there's rules and procedures for that. The other thing is that after the treasurer imposes the fine, it says the manufacturer can then seek reconsideration under Title 36, which is the main revenue statutes. And there's a whole process in Title 36 that talks about how taxpayers can challenge assessments. And that seemed duplicative. I mean, if there's already going to be, so we're really having now 3 levels of sort of review process. We're having this thing where it gets submitted to the Superior Court for approval. Then we have this thing where they can appeal the decision to a court, that has jurisdiction over such matters. But then there's this third thing that says they can go to Title 36. So it just seems like that should be cleaned up to have a very streamlined sort of appeal process rather than these sort of three separate things. It also wasn't clear to us how many years this fine would be applied, because the definition says that an identified drug is one that's been identified as having an unsupported price increase at any time. But then there's some language in the bill that suggests that maybe that the fine will only be imposed for 2 years, but it really wasn't clear to us sort of once a drug has been identified as having an unsupported price increase, does it then get fined like every year into eternity, or is it some definite period of time? So those were all just things that we thought should get sort of clarified or cleaned up at some point.
Okay, thank you. I'm trying to write things down.
And I know I said that very quickly, so I'm happy to go back over it if that would help.
No, I got them.
I also just want to flag, and this was an issue that is also in the other bill, but I don't think I addressed it there. There's this provision that says that basically if the manufacturer wants to try to avoid the fine by withdrawing the product from the main market, it's going to be fined $500,000. That's also something we haven't seen before, and it kind of raised some concerns in our mind. I mean, typically with sort of like price control statutes, it's ultimately up to the seller whether it wants to sell at the price or not. So like, if someone sets the price of milk in a state, a dairy is free to say, hey, I don't like that price, so I'm just not going to sell my milk in Maine. It's a little bit unusual to have a statute that says, like, even if you don't like this price, like if you don't sell at the price that we've set, we're going to fine you $500,000. I don't know of any cases that have addressed something like that. We couldn't really find anything easily, but I think it could maybe lead to like a takings argument that you're essentially requiring us to sell our product at a price that you've set, and we don't have the ability just to walk away from the market. So that's just one other issue that we saw with the bill.
Mr. Taub, in your view, is this bill distinguishable from the DC case?
Not the patent preemption issue. I don't think that's distinguishable. I think if we were in the DC circuit, I don't think that this would survive in the DC circuit under that precedent. I don't see a way to distinguish it. So I think if this law got passed and we were defending it here in Maine, I think our argument would be that the DC circuit got it wrong.
Mr. Taub, given that it's about patent law, that argument, would it be possible for the manufacturers to bring the suit in the federal circuit, which is what deals with patent law?
Well, that's an excellent question. I don't know the answer to that. I don't know. I've never litigated a patent law case before, and so I don't know whether or not the federal circuit might be the court that would have jurisdiction. I suspect that, well, I just don't know the answer. That's a very good question.
I don't know the answer either, but I think it's possible.
It's definitely possible. I would not be surprised.
Okay. Are there additional questions for Mr. Taub? Okay. So seeing none, I'm going to bring in Mr. Gatine. There really are different issues here, even though they're the same people. So we really need to go over this. I'm going to bring in Mr. Gatine. Welcome back, Mr. Gatine. You can speak to the question of whether this bill is distinguishable.
Yeah, again, glad to have the opportunity to be here. Glad to have the opportunity to hear Chris's points. Again, on the Commerce Clause issue, I don't think his point of view and our point of view is really different from the previous bill. Again, we drafted this bill to make sure that the transactions that are being focused on are transactions within state, which I think in the opinion of our legal team distinguishes it from the Frosch case. With respect to the bio case, the DC patent law case, again, we did look at that case. Our legal team did look at that case when we were drafting this bill. The way that they distinguished that was that the bio case was regarding a law that applied just to patented drugs. This bill is actually neutral in terms of its application to generics or patented drugs, which again our legal folks felt was distinguishable from the bio case.
Mr. Gattine, do you have any answer to the question about venue?
I don't.
Are there additional questions for Mr. Gattine? Mr. Taub, I have a question about fines that I want to go back to if nobody's kind of on this unconstitutionality issue. Representative Tepler, do you want to talk more about the constitutionality question?
And the patent law issue, just using Mr. Google, this indicates that the decision of any U.S. district court can be appealed to the U.S. Court of Appeals in trademark cases and copyright cases.
And what I don't know if that same would apply to a situation where it's not like a trademark dispute or a patent dispute. It's not like a patent infringement or a trademark dispute. It's a preemption argument that patent law preempts it. And typically, preemption cases, there are all kinds of statutes, federal laws that people bring preemption challenges. They'll say this law is preempted by this federal law, by that federal law. Typically, those get brought in the state where the law was enacted. But I don't know whether because it would be patent preemption, whether that might somehow change the venue. But yeah, that is a very good question.
Yeah, I think the patent venue statute only applies in infringement cases. I don't think it necessarily applies to challenges to the underlying law. So it may not be that there's federal circuit jurisdiction. I don't know. And I might be confusing two different classes that I took in law school 20 years ago as well. I think that's quite likely.
For what it's worth, that's just kind of my hunch too. My hunch is that this would get brought in Maine, not in the federal circuit.
Okay.
It's just a hunch.
So my other question, Mr. Taub, is there's somebody who did way better at law school than I did, who just raised his hand. So we may bring him in as well. So there's another question that I have, a rabbit hole around how the fines are imposed, because you pointed out some drafting concerns with regards to the imposition of fines here. I think this was an attempt to respond to thinking the process wasn't correct in the original bill. Can you tell us another sort of area of law where we impose fines as a government? And then there's like, what's the procedure for that?
I mean, at least for our office, it's typically we go to court and, there'll be a statute that will say, a violation of this law, a fine of up to, X dollars per day or per violation may be imposed by the court. And then we would go into court and we would prove up the violation, and then the court would set the fine. I think that's fairly typical. I don't know about the licensing boards, like if the licensing boards have independent authority just to impose fines. But at least in my experience, the more sort of traditional route is to go to court first, and then the court imposes the fine.
Got it. You don't go to the court with the fine, you go to the court with the violation of the law, and then the court sets the fine based on the statute.
That's been my experience, yeah.
Okay. All right, I'm gonna bring in Mr. Regal. Good afternoon. Welcome.
There it is.
So your hand went up when I started butchering patent law, so I was thinking you might have an answer to that piece for us.
Yes, thank you very much, Nolan Reichel on behalf of Pharma. I got a few points, but let me just address this procedural issue that was raised. So if you go back to the biotech industry versus District of Columbia case from 2007, that case was decided in the federal circuit. It was brought in the United States Federal District Court for the District of Columbia. So at the trial court level, it was adjudicated in the federal court of the jurisdiction where the bill was passed. On appeal, it was transferred to the federal circuit. And if you look at the case, the first half of the case is a discussion of whether the federal circuit could exercise jurisdiction over the appeal, and the federal circuit concluded that it could. So if there were a challenge based on this patent preemption argument, it could be brought in federal district court for the state of Maine, and then it could be transferred on appeal to the federal circuit. And I think what that means is that in the district court proceedings, the district court very well may feel that they are bound by the federal circuit's decision in that case, which, as Deputy Attorney General Taub rightly states, I think would be a dispositive decision with respect to this legislation.
Mr. Reichel, can you speak to why including generics as well as patented medicine in this bill doesn't cure or distinguish it from the bio case?
Yeah, I mean, the patent laws are offended by the statute. And just because the statute may affect other types of drugs doesn't mean that the patent laws are not offended by the statute. So layering in additional classes of products, whether they're medications or not, but layering in additional classes of products that are not subject to patent doesn't change the fact that it violates patent law. So that wouldn't change the outcome here in any way, in my opinion.
Okay. Are there additional questions for any of the three folks that we've got in the panel now? All right, I'm not seeing any, so I'm gonna thank each of you for joining us, and I'm gonna send you back. Maybe I'm not able to do it. Maybe someone else can do it. There we go. Okay. Before I move to table, is there any further discussion on the bill? All right, so it's not as late as I thought it was going to be. So I am going to suggest that we reconvene at 4:45, and we'll see at that point where we stand. Oh, I have to table the bill first, though. I guess I don't have to. We could just corner caucus it, but I'll table the bill instead. So Representative Tefler. She moves to table. Representative Tefler seconds my motion to table. Great, perfect. And now we can raise our electronic hands with my handy dandy new theory of how this is easiest. And so it's unanimous of those present to table. And we'll be back here at 4:45. Darlene, do you need something? You good? You were just counting. Okay. It was all of us. I think Colleen got it. All right. Okay. We'll see you back here at 4:45. All right. So thank you for the time. This is going to be a little bit anticlimactic because we are just going to adjourn. We anticipate that we'll pick this up tomorrow, and obligations and schedules. So we will send out a notice either later tonight or tomorrow with the exact time. It will be at 11 o'clock or later because we've got some conflicts in the morning. But we're still trying to coordinate all the schedules. So and it'll just be, I think, these two bills, and then we'll deal with the carryovers tomorrow as well, since we'll all be together anyway.
I also have some language reviews, which we can do tomorrow as well.
Okay, yeah, let's do those tomorrow since we're going to convene at some point tomorrow anyway. I think that makes sense, and then we can adjourn before 5 tonight and try and regroup a little bit. So I apologize, Representative Morris, for holding you for another half hour on this beautiful evening, but we've got some more work to do.
I still have to be in labor anyway. So I did want to just, for my scheduling tomorrow, I do, the apportionment committee is meeting at noon as well. So I don't know how long that will be, but I'll have to bounce back and forth if we go too long.
Okay.
Yeah.
Do you anticipate it? Is it usually more than, I don't know if you've met yet. Is it more than?
We have not. We don't have the numbers yet. So.
Yeah. Okay. And you still don't have the numbers, right?
No, we won't have them until September. So.
Okay. So it might be.
Might be.
Okay.
But I think, yeah, absolutely.
Okay.
Yeah.
All right. Well, that's helpful. We'll try and schedule around that and potentially, pick 1 o'clock or something as well. And we'll just have to figure out how all the pieces fall into place with all the different schedules we're trying to navigate around. So, okay. So with that, I think we will adjourn for this evening, and we'll send out a committee notification as soon as we possibly can with regard to when we will convene the work sessions tomorrow, but the intention is to be back in work session tomorrow.
Okay.
All right. Thanks, everybody.
Thank you.
Thank you.
Night.
Good night.
Good night.
Darlene, do you want me to call you about the DCR, or you want to send it to me? Sounds good, thanks.
Darlene, Colleen, can you hear me?
Yes, I can.
Can somebody send the link tomorrow for tomorrow's
Yes,
work session?
we will. We'll email it out to everybody as soon as we know what time. Yes.
Okay, yeah, because I always get it lost.
Yeah, we'll make sure, and I'll try to remember to send you another one right before we start, so you can
Okay.
right at the top of your email.
Okay, thank you.
All right.
Good
Thanks.
night.
Good night. I can't hear you. Are you talking to me?
Why? Okay. Can you hear me now?
I can.
Okay, so I did it. It's all on my desktop, and I'll forward it to you in an email. Should I even put that they did a work session on the last two bills or not?
Yes, 675 and not the work carryover ones.
No. 675 and 1117.
Yes.
Just put work session.
Table.
Don't put tabled. Okay,
Yeah,
even though
they did talk about those and they tabled them.
Oh, that's right too. They did make the motions to table.
My notes had that. Yeah.
Yeah. No. I wrote it too.
Okay. Perfect.
Just not on a vote sheet. Okay. I'll send it right to you.
Perfect.
And then you'll let me know what time.
Yes, as soon as I know. Yeah. Should I let you know, or Annie and Casey? I'll just let all of you know. Probably.
Yeah, let all three of us know. And if I'm still here, I'll do it because they are going to be here later than me probably. But I'll be here for a while.
All right. I may not know tonight, but I'll send you as soon as I know. So.
In other words, don't sit around and wait to hear from
No,
me.
don't wait for that. Yeah, I'll just send it to them if they, I'll send it to them. but, you
Send
know,
it to them
I
and
don't
they'll
think
take
you need to stick around. Yeah,
No, oh my God, I got so many master files to do. It's ridiculous.
I know. We all have a lot to do, but okay.
Yes, we do. Okay. Very
Super,
good.
thanks.
Yep. Bye.
Bye.
Mm.